Good afternoon, everyone, and thank you for joining us for the Medical Board of California Quarterly Board Meeting. Pursuant to the provisions of Governor Gavin Newsom's Executive Order N29-20, dated March 17, 2020, this meeting is being conducted via WebEx. Public comments will be heard for each agenda item for individuals wishing to do so. To be ready for public comment, we ask that you please ensure that your comments can be heard clearly by connecting to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you are connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the top of the WebEx application or the audio and video menu option at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will still allow you to participate and hear the audio of the board meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, President Lawson. You can now start the meeting.
Thank you, Sean, and good afternoon, everyone. Welcome to the Medical Board of California's first quarterly meeting of 2022. Please do mute yourself, turn any devices to silent, please, so that we don't have any interruptions. Since this meeting is being conducted via WebEx, I will ask all board members and speakers to please announce themselves by name before speaking, and that's for clarity of the official record. All board members are able to unmute themselves to speak during the meeting. Please place yourself back on mute when not speaking to reduce the background noise for all participants. Following this online meeting etiquette will ensure the best audio quality for everyone. During each call for comments from board members and speakers, we will ensure that all comments that can be accommodated are heard before proceeding with the agenda. Government Code Section 11126.5 does allow a board to remove people who willfully interrupt a meeting and to clear the room or virtual space if order cannot be restored by removing or muting the disruptive people. We have a designated time on the agenda for public comment, and we will ask for public comment on each agenda item. This is an official business meeting of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call upon those individuals who indicated they wish to make public comments by name. When called upon, the host will unmute the microphone of the individual and they will have 3 minutes to make their public comment. The host will audibly announce when 15 seconds remain to conclude the public comment. And after the 3 minutes have lapsed, the individual will be placed back on mute. Only one public comment per agenda item will be permitted per attendee. And again, please do see page 4 of the agenda for WebEx instructions on how to connect from the link on the agenda and for additional helpful instructions. During agenda item 2, public comment on items not on the agenda, the board has limited the total public comment period for individuals to 40 minutes. Therefore, after 40 minutes, no further comments will be accepted. During public comment on any other agenda item, 20 minutes will be allowed for each comment period. And after 20 minutes, no further comments will be accepted. Each person, again, will be limited to 3 minutes per agenda item. The board's IT staff will assist me with receiving public comments via WebEx during this meeting. And I would like to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law, and we plan to end today's meeting by 6:30 p.m. I would like to now call the meeting to order at 2:07 p.m. and ask that board members unmute their computers. Ms. Caldwell, please call the roll.
Mr. Brooks, Ms. Campoverde, Dr. Gonadev,
Here.
Dr. Hawkins,
Here.
Dr. Hilzer,
Here.
Ms. Lawson,
Here.
Ms. Lubiano,
Here.
Dr. Mahmood, Mr. Rue, Dr. Thorpe,
Here.
Mr. Watkins,
Yeah.
Dr. Yip.
Yeah.
Thank you.
Thank you, Valerie. I believe a quorum is present. Board members, please do remute your computers. I would also like to remind the members again that on each each action item, we will be taking a roll call vote. We'll now move on to agenda item 2, which is public comments on items not on the agenda. And before I ask for public comments, I would ask individuals that are making public comments to please not discuss any pending complaints, pending license applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications, as they could provide information to members that is outside the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to a board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances where the decision is still pending. In addition, the board would like the public to address the board as a whole and not individual members. Please be aware that public comment during this agenda item should provide information to the board members, and it is not a discussion between the board members and the public. The only action board members can take is to listen to comments and decide whether they want a future agenda item on the topic. No other action can be taken on the item at this meeting. Though this may seem at times like the board members are not being responsive, following these guidelines is critical to ensuring the rules of the Open Meeting Act are followed to avoid compromising the speaker's goals and the board's mission. If you want to comment on an agenda item, please do wait until we get to that agenda item. Comments at this time are only for items not on the board's agenda. Please limit your comments to 3 minutes. I will now ask the host to call for public comments. Sean?
Thank you, Ms. Lawson. And for anyone calling in not connected to a computer, you can use the *3 function on your phone to raise your hand through the phone line, and then when you're called upon, you can use the *6 option to unmute your phone. And for those that are raising their hand and putting in the Q&A box that they would like to make a public comment, as I call on your name, you're going to get a prompt on your end to unmute your microphone. It's not an automatic thing anymore, so you will have to acknowledge that prompt in order to speak. First request we had was from Virginia here. Virginia, you should be receiving that prompt now on your end. And Virginia, your line is open.
Can you hear me?
We can.
Okay. Hello again. So there's been a lot of talk of evidence-based, science-based information lately. And what I have noticed is that a lot of the laws and statutes that you follow were developed by powerful white men with special interest and not based on patient safety or any safety. So it's really concerning that evidence-based and science-based is so important, but yet your very foundation, there's no evidence to it. And when you do find something that's wrong, like last meeting, you're trying to put a new law in on how evidence, you're met with these powerful white special interest groups that has more power than the medical board. And it's absolutely terrifying that the CMA is more powerful than you. It's terrifying. You guys have no power over the CMA. And by them taking up other people's laws and not your laws, it's extremely eye-opening and concerning. They affect patient safety on several levels, like limiting publishing of accusation on medical board sites. Now, other people have been hurt, and then they're thrusted into MICRA because you guys can't publish accusations on your site. They abuse lobbying power. There are people that have been 5 years before they go in front of you. In those 5 years, hundreds of people have been hurt, and those people have to face MICRA. They're left impoverished, homeless, with PTSD, disabled, and all of this is the lobbying efforts of MICRA. I mean, the CMA, and you guys do nothing about it. And they stonewall legislation time and time again, and you guys do nothing. What are you going to do to have power over the CMA so you can get laws in place that protects patients that are evidence-based, science-based, instead of lobbying-based? Because it's terrifying watching you guys. It's also terrifying that I can't get accurate medical records to follow me wherever I go with Epic. Because my records are all lies. I have PTSD and I have to explain their lies, and they'll believe the doctor over me. is terrifying. Absolutely terrifying to go to the doctor. And I should have gone to the doctor a year ago. I finally just went, and I have something that probably will limit my life. I'll probably die 6 years younger than I would have if the doctor did what I said and if I was safe to go to the doctor. So something needs to be done. I keep saying trauma-informed care. So I can
Seconds remain.
doctor that's trauma-informed, that understands trauma and trauma impacts the brain, but you guys stonewall that and will never bring it up to talk. So I appreciate if you bring trauma-informed care into your talks and integrate it into medical CMUs and do something about the CMAs affecting all your ability to put proper evidence-based safety laws in place. Thank you.
Thank you for your public comment. Up next, we have Susan Lauren. Susan Lauren, you should be receiving the prompt on your side.
Hello.
We can hear you,
Can you
Susan.
hear
Please
me?
go ahead. Yes.
Thank you. You recently put out a call for medical board experts. One of your experts, plastic surgeon Dr. Terry Dubrow, was excluded as a TRICARE authorized provider for a period of 10 years because he, quote, retained the beneficiary's advance payment despite being made aware on multiple occasions that his actions were contrary to federal regulations. This affected military members who have sacrificed so much for their country. End quote. Why should Californians trust Dubrow when the military health agency doesn't? Now, Dr. Sahlberger ended my healthy quality life when I initiated breast reduction surgery with him. Against need, consent, or rationale, he removed flesh I didn't have to spare, cut through deep structures, left me disabled, disfigured, in extreme pain, and no longer able to work, my lifetime potential cut short. Once I grasped what he did to me and tried to bring justice and secure needed restitution, I faced a band of brothers who cover for each other. The referring physician, Dr. Donna Cashton, failed to perform and or document a systemic examination of injuries Berger caused. Yet other doctors, physical therapists, and state disability recognize damages as severe and disabling. State disability has me on an SSA stipend, which isn't enough to live on. Yet the medical board hires Dr. Terry Dubrow, who lied in my trial, thereby denying me restitution. Tom McAndrews, Berger's lawyer, sold Dubrow to my jury on the basis that he is a medical board expert. Quack doctors abused me with unneeded, harmful medications because Berger lied and said I had factitious disorder after his surgical battery of me. By ignoring my valid complaint against Berger, the medical board made it impossible for me to successfully report other dangerous doctors. One threatened to withhold sleep medication and to medicate me for conditions I don't have if I didn't talk to him in detail about oral sex and other of his perversions. His son, a doctor, was recently found guilty of sexual misconduct. Lies by this and other deviants are in my record. Now, Berger assaulted me. Dubrow covered for him. They violated Nuremberg Code of Ethics and desecrated my body and life. The fact that you licensed Berger after assault, fraud, and slander and used Dubrow as an expert is proof your board aids and abets atrocities. The medical board is supposed to protect the public, yet you allow your experts to be called as expert witnesses against plaintiff patients. The board affiliation confers authority to these witnesses in court that is used to sway the jury against patient victims. This is a complete contradiction of roles. So stop letting medical board experts testify against victims in court. Stop using Terry Dubrow as an expert. Add surgical battery to your consumer page. Change California Liposuction Code 1356.6 and request emergency restitution for victims of California's medical mafia like me. Seriously, do it. I've lost over $650,000 so far, and it's not right that I'm suffering and don't know if I'm going to have a decent or any roof over my head because of what this crew has done. I want help. Seriously, I want you to talk to the legislators. Thank you for listening. Please do.
Thank you for your public comment. Up next here we have Dr. Ree. Let me find your name here. Dr. Ree, you should be getting the prompt on your end. Dr. Ree, if you could accept the prompt to unmute your microphone. There you go.
Yes, thank you. I didn't realize the prompt would be coming through the computer. Thank you. Yeah, so I wanted to start off discussing some other issues, but in support of the previous commenter, it's true, medical board. I think I brought up in the past that there is a serious situation occurring with a UCSD, University of California tenured professor that has sexually assaulted, raped a trainee. So this issue of physicians covering for each other in cases of sexual assault has got to stop. So this case, I'm telling you, is going to be coming up quite soon. But in the meanwhile, I wanted to mention to you about our concerns, our ongoing concerns, that the majority of the board members, not all, but the majority, and also the medical experts and the consultants that you're using have, still no work history, no significant recent work history in diversity, whether it's racial or religious diversity, as evidenced on their resume. And so we now in the 21st century, 20 years into the 21st century, it really is relevant and important. So with our federal civil rights lawsuit, number 2:18-CV-105 in California Eastern Division, filed in 2018, remains active and ongoing. And recently, the federal judge denied the defendant's motion to dismiss the case, and it's allowing us to continue to sue several state attorneys, including the previous attorney general. So I want to bring to your attention the practice, most recently, of the state attorneys, the ones that you all are paying for, that have been practicing medicine in the courts without a license. And in fact, instead of utilizing
30 seconds
a
remain.
board-certified physician, medical expert, the attorneys are making the diagnosis using a training manual. How is this allowed? How are we funding this and paying for this? So in any event, it's an important subject. I'm not quite sure yet who to address it with, but I just want to bring it to your attention. Thank you.
Thank you for your public comment. Next up, we have Marion Hollingsworth. Marion, let me open your line here. Okay, Marion, you should be receiving that prompt on your end.
Can you hear me?
Okay, we can, Marion. Go ahead.
Thank you so much. Good afternoon. My name is Marion Hollingsworth, and I'm a patient safety advocate. You have no doubt read the articles in the LA Times regarding issues with the medical board. What really caught my attention in the last article was that board president Christina Lawson was quoted as saying, "We're listening, we want to improve." This was a stunning quote because for so many years, this board has refused to listen to advocates about most topics and has steadfastly dug in its heels about any change. You only change when you have no choice. An example is patient safety notification about probation. In 2015, this board voted against doctors telling patients they were on probation. You then went on to oppose Senator Hill's first two bills to require that notification. Dr. Gananadev spoke against it at the 2017 Sunset Review, taking the CMA position that it would hurt the doctor-patient bond. It was only after the massive Larry Nassar and George Tyndall sexual misconduct scandals that you finally had to agree that patients should know if their doctors were on probation, especially for attacking their patients. This board has not wanted to listen to advocates for years. In fact, some members have even called on the AG's office to step in to stop us from speaking because you didn't like hearing what you call criticism, and that's what we advocates think are changes to protect patients from harm. Dr. Krause and Dr. Wormuth and Mr. Wormuth even stated at meetings that we should be silenced. At the last in-person stakeholder meeting, Dr. Lewis even asked, why are there the same advocates at quarterly meetings? And I can explain that. Maybe we're the ones who haven't given up on you. Maybe some of us think there is still a chance that you can change and protect patients instead of doctors. At the beginning of last year, Mr. Pacifica said he planned to have 4 stakeholder meetings, but there were only 2. The rest were apparently canceled because the board wanted to control the topics and refused to listen to topics consumers wanted addressed. Again, no listening. So now, because the CBS and LA Times are covering your failings in news reports, now you want to listen and improve. Well, if you really want to listen and improve, talk to us. We have been through terrible loss or harm, so we understand the need to make changes more than you do. You have no problem talking to the CNA and even being speakers at CMA events. We, more than anyone else, want you to improve so that fewer people die or suffer at the hands of unscrupulous doctors. We need as many good doctors as we can get.
30
So
seconds
work with
remaining.
us. We may just surprise you with our ideas. Thank you.
Thank you for your public comment. Up next here, we have Kristen Ogden. Kristen, I'm sending you that request now. If you can, looks like your line's open, Kristen.
Can you hear me?
We can. Please
Okay.
go ahead.
My name is Kristen Ogden. I'm speaking for Families for Intractable Pain Relief. Thank you for the opportunity to comment today. It's a busy week for those who follow developments in regard to pain and pain care. Earlier today, the new draft CDC guideline for opioid prescribing was released for comment. We saw release this week of the report of the Commission on Combating Synthetic Opioid Trafficking. Several items of interest are on the agenda for this meeting, and there are continuing rumors that some seek to eliminate California's intractable pain law and Pain Patients' Bill of Rights. We've sent our concerns in writing, but here are the overarching issues. Legislators, regulators, and the general public do not understand or acknowledge that severe, constant, life-altering pain really exists. Physicians continue to abandon the practice of pain care. Where does this leave us? Procedures and surgeries help some, but not all patients. Pain medicine is no longer allowed in many places. Many cases of untreated or undertreated severe pain continue, and they lead to predictable, life-threatening complications, including measurable cardiovascular and endocrine dysfunction that in turn leads to heart attacks, heart failure, strokes, and premature death. The war about compassionate pain care continues. We have doctors who still believe in relieving pain and suffering, but we have a lot of people who believe prescription opioids cause the entire opioid overdose problem and that opioids are inherently bad and should be banned and eliminated. We have anti-opioid activists. Let me give an example. Doctors Jane Ballantyne and Mark Sullivan, October 21, published an article in the Journal of Pain and said, quote, "We need to demedicalize pain and reintegrate it with the rest of human suffering." We are living in a time when compassionate care of pain has become politically incorrect. Our bottom line is that we want to see restored access to medical management of pain in California. I'd like to conclude my comment with a statement for your consideration. In the words of Judge Peter J. Wilson, November 1st, 2021, Superior Court of California, County of Orange, quote, "While the court recognizes that the FDA has on occasion announced a concern that claims about improved function should not be made absent scientific evidence, the court is persuaded, based on the evidence in this trial, that effective pain management and improved or improvements in function are closely related concepts. It seems beyond debate that for a patient whose pain has been sufficiently controlled that they are able to resume some of the basic functions of life, shopping, cooking, cleaning, and so on, that patient's function
30 seconds
has
remaining.
improved." The words beyond debate, stated another way, it's a no-brainer, folks. Please consider and keep this thought in mind as we proceed through the agenda for this meeting and as work continues on revising California's prescribing guideline. Thank you again for the opportunity to comment.
Thank you for your public comment. Up next, we have Eric Andrews. Eric, let me get the request to you. Eric Andrews should be getting the request on your end now. Time here. There you go, Eric. Your line's open.
Can you hear me?
We can.
Okay, that took a long time for it to propped up, so just so you know.
Hi, everyone. Happy New Year, albeit still with COVID lingering. How many of you thought, like me, that when it first started, it would be around 6 months tops? At least with these online meetings, we're not stuck with expensive airplane tickets and exorbitant parking costs. So how about those LA Times articles, huh? It seems our hard work, research, and documentation of everything you guys do and don't do is starting to pay off. A big thank you to reporters Jack Dolan, Brittany Mejia, Melody Gutierrez, and Kim Christensen on such a great job on this ongoing series. And yes, it will be ongoing, Christina, much to your chagrin. I recently stumbled on an old article that says, quote, the medical board also voted to disclose whether a physician is a registered sex offender and to make investigations of physicians public after the board refers cases to the state attorney general's office, rather than waiting for a formal accusation to be filed. The medical board approved the proposed disclosure requirements after an Orange County Register report found that the board investigates only about 20% of the 10,600 complaints received from patients each year and does not disclose most complaints to the public, close quote. That was just May of 2002. And here we are just 3 months shy of 20 years later, and next to nothing has changed. We know that the board effort never came to be, and you're still not disclosing important information to the public. 20 years later, folks. And yet Christina expects the public to salivate over her promise that the board is listening. The board has never listened to the public unless the public can get the press to write about it, as the LA Times and other news outlets are doing now. It is sickening and pathetic, the hoops we have to jump through to make you all attempt to do your jobs properly. The number one lesson here is that you've never been trusted. You can't be trusted. Marianne touched on this, but remember when Bill told everyone that we would have 4 stakeholder meetings a year at the May 13th, 2021 quarterly meeting? We had 1 more stakeholder meeting after that, which was a disaster. Patient advocates were irate that Bill was attempting to hijack the agenda to only talk about things he wanted to talk about. So what happened after that? Well, apparently he had a hissy fit and canceled all future stakeholder meetings. So much for caring about what the advocates have to say and listening to us. Go to our website, forpatientsafety.org, and look at the 130 plus articles we've collected.
30 seconds remaining.
All about how bad the medical board has been for the last several decades. Oh shoot, now I'm running out of time. We're keeping track of everything you do wrong, including all the illegal Public Record Act requests that Carrie Webb continually shuts down. And trust me, eventually it's all going to come back to haunt you. And I've got more to say, so I'm going to have to try to put it on later. Thanks.
Thank you for your public comment. Up next, we have Coda J. There you go, Coda. I see your line's open. You can.
Hello? Did I do it right?
Yes, your line's open.
Okay, great.
Please go ahead.
Hi, my name is Jules Coda, and thank you for the opportunity to speak and ask questions. And I have to start by saying that it's been so informative being able to listen in on these meetings over the last couple of days, and that the public is able to tune in and listen, because most of my questions have been answered just by listening to what is available for us to listen to. So I want to thank the board for that. And I know that people are really angry when they come at you with these questions. And if I had this opportunity maybe 2 months ago, I probably would have sounded like them. And my heart is broken like theirs is. Which leads me to my questions. You know, I've been working with the board. I have a case, you know, that I'm dealing with that, again, we were reminded not to be specific about our cases. And my questions aren't necessarily specific. They're more in general about process and protocol. And I did submit some questions that I listed. Again, a lot of these have been answered for me simply by listening and reading through past meeting minutes and listening to the discussions of the cases. So my main questions are going to be about like literal protocol for when a complaint is filed. And it's very clear that the board has been scrutinized about this. And it's also very clear that they are starting to take action. I see that now. I did the research. I read all of these items that are on the agenda about involving patients and victims' families in disciplinary actions, keeping a liaison program attached to complaints. And I think these are all really positive steps to be looking at and entertaining and deploying. And so I'm really grateful for the board for that. It answered a lot of questions for me. But the number one thing that I keep seeing over and over again is the lack of what I'll use a medical term for is triage. I still don't see where there's a triage of the complaints that come in. And in my very limited experience working with boards, I hold a state license for cosmetology. I know that that's very different. Nonetheless, I do have to deal with state board, right? So I know how complicated it can be. And drawing from my own experience working hand in hand with the board as a liaison for my community to help
30
change
seconds remaining.
regulations, thank you, to help change and update regulations, it was proven to be really, really effective in our industry. And a lot of people had really positive outcomes. So I have faith in boards and in boards changing, and from my own experience. And I wanted to point out that I see that happening with you guys. So I appreciate that. However, I still want to know exact qualifications for these people who are making these kinds of decisions about where exactly a complaint gets sent to. Specifically when there's criminal activity, blatant criminal activity involved, is it immediately deferred to law enforcement? So things like that, I think the general public would be really glad to know there was like a very clear step-by-step protocol. Thank you.
Thank you very much for your public comment. At this time, President Lawson, I do not see any additional requests in queue.
Thank you, Sean, and thank you to all the public commenters. I did want to note for the record that Board Member Rue has joined us as well. So welcome, Mr. Rue. We're going to move on to agenda item 3, which is a presentation on chronic and intractable pain. Dr. Mackey is joining us for this presentation. Dr. Mackey is Chief of the Division of Pain Medicine and the Redlich Professor of Anesthesiology, Perioperative and Pain Medicine, Neurosciences and Neurology at Stanford University. Under Dr. Mackey's leadership, the Stanford Pain Management Center has been twice designated a Center of Excellence by the American Pain Society. Dr. Mackey is the past president of the American Academy of Pain Medicine, is the author of over 200 journal articles and book chapters, and co-authored the Institute of Medicine's report, Relieving Pain in America. Dr. Mackey, I will turn this over to you.
Dr. Mackey, I've moved you into the panelist role. You can use the controls now at the bottom of the screen to start your video and unmute your microphone. There we go. And you also will see the share button down there to go ahead and start your slideshow when you're ready.
Perfect. Thank you. Thank you. Allow me 1 second, please, just to. All right. I want to thank the medical board, and I also want to thank the patient advocates out there that I understand express their voice in wanting somebody to come by and talk about the issues around chronic pain, around intractable pain. And my sincere congratulations to you. Your voices have been heard, and I hope that I can provide some useful information to the board and to those who are listening in today. I want to start off with a couple use cases that may be of relevance to people on the board, to the listeners here. And I want you to imagine for a moment that you're a primary care doctor, that you've just been handed a panel of a couple hundred people who are taking opioids, and you're wondering what in the world you're going to do in your busy practice to help manage these patients. Another use case might be you've got a number of patients who have chronic pain, who have been on chronic opioids, who have been behaving themselves, if you will, have been functioning well, have been doing well, and yet you're getting pressure to wean them down because of external pressures. And, you know, a third case might be for people who are listening in who have chronic pain and have had a difficult time getting access to safe and effective therapies for themselves to help better decrease their pain, improve their function. And my goal during this brief period of time with you is to talk about some of those issues and to offer up some potential solutions that are not my solutions per se, but instead solutions that have been put forward by a number of national committees, a number of ones in which I've been on or even led, and have been developed through broad representation. And I'll submit to you both now and at the end, what we don't need is yet another committee to determine what to do. What we need is the will to move many of these recommendations forward and to implement them. And so let me start off with that. By way of brief introduction, as was mentioned, I'm the Redlich Professor, and I'm the Chief of the Division of Pain Medicine at Stanford University, where I've been for about 25 years. I am a physician scientist. I both care for patients with pain, although I only care for patients about 1 to 2 days a month these days. Most of my work is in the doing research or in doing policy work. My research is broad, but if I had to focus on two major areas, I'd say it's around neurosciences related to human pain. I do a lot of brain imaging work to help open up windows into people's brains to understand where pain is processing, perceive why people uniquely experience pain the way they do, and what happens when pain goes bad. And then secondly, I've had a passionate interest in helping to develop high quality evidence through data collection on real world patients to help inform our decision making and to help determine, are our treatments actually working, and to design new therapies. And I'll touch base briefly on some of that. So let me now share some of my slides with you. And my question is, are the slides coming across, and are you seeing them?
They're just starting to load up here, Dr. Mackey. Do you have another prompt on your screen? Maybe it's saying it says it's starting to share content, but I'm not seeing it come through yet.
It says you're sharing the whiteboard.
If you go down to share again and you actually select the app like PowerPoint or what you're trying to display, the whiteboard's like a drawing surface.
No, I'm with you there, and I actually did do what you said, but let me try that again.
Oh, there they just loaded for me. Maybe they loaded quicker for everyone else, but I can see your solutions for the.
Yeah, I don't want to. Give me 1 second here.
Sure.
Also, so this is still loading up.
Dr. Mackey, I'm seeing your presentation now. Are other board members seeing it as well? Yeah, great.
I'm seeing it now as well too. Thank you.
All right. Give me 1 second. Because things are operating quite a bit slowly. So let me move on to the, let me see if I can get the next slide going here. By the way, I should also mention in my financial disclosures that all of my funding for research and otherwise comes from either the federal government or from philanthropic sources. I don't have any industry funding, I haven't engaged with industry for more than 15 years. I'm a salaried faculty member at Stanford, and I do not get more money by seeing more patients, nor do I get more money by bringing in more grants. It's pretty much a salaried job. And I mention that just to give you a sense of where my focus and influences are. For the last number of decades, I've been focused exclusively on finding solutions for those who are living with pain and defining better, safer, and more effective therapies for them. My position on opioids, because I think we are going to be getting into some of this, is that I am not pro-opioid, I'm not anti-opioid, I am pro-patient. And I'll speak to that more shortly. 1 second here. Let me do a little bit of a check here. What slide are we currently on, just so that I'm...
I'm seeing your disclosures slide. Now I'm seeing your public health slide with some news media.
Okay. Got it. So folks, we are facing clearly a public health crisis in pain, and barely a day goes by when we open up a news report and see a problem of pain. And, what is the magnitude of that that we're facing? Well, this has been outlined clearly by the Institute of Medicine report on pain. The IOM is our country's main nonpartisan advisory group for all things in healthcare, engineering, education, and sciences. And I was on a report that helped define the blueprint for where
Okay, I think Dr. Mackey might be having some bandwidth problems because we just lost his connection.
Okay. We'll take a pause here. We'll see if we can get him back, and perhaps he can just either proceed without his presentation, or maybe, Sean, you can control his presentation.
Yeah, we can definitely try to do that. If he's losing connection, though, we might lose him audio too. So see if I can.
Should I advance us to agenda item 4 while we try to get him back on the line?
I don't think that would be a bad idea for sure. Yeah, I'll see if I can get him back in.
Okay, let's advance to agenda item 4, which is approval of the minutes from the November 18th through 19th, 2021 meeting. Members, please do unmute your computers. And are there any additions or corrections to the November 18th, 19th, 2021 board meeting minutes from the members?
TJ Watkins. Yes, Madam Chair. I have a few, but I will just send it straight to Valerie, just to keep us moving forward.
Sure. Could you just advise us to the nature of the comments? I just want to make sure the public is aware of what's being modified.
It will be in. Wow. I've got the latest. I did this notes on the. I'll get back to this because I have the latest version of it, and I didn't highlight it on the latest version.
Okay. Are there any other members who have additions or corrections to the board meeting minutes? All right, seeing none, may I have a motion to approve the November 18th, 19th, 2021 board meeting minutes as submitted? And we'll come back to Mr. Watkins after we take public comment, and perhaps he can identify his additional comments then.
Dr. Hawkins, so moved. Second.
Thank
Dr.
you.
Thorpe.
Thank you, Dr. Hawkins. A second by Dr. Thorpe. I am now going to ask the host to call for public comments, please. Sean.
About that. Let me get this open here. Okay, the Q&A window is open for anyone wishing to make a public comment. You can raise your hand or type something in that box. And also for the call-in users, if you're interested in making a public comment, you can press *3 on your phone, which will raise your hand so I can call on you that way. First up, we have Dr. Ree here. Let me open your line. Should be getting that prompt now on your computer to unmute your phone. And there you go.
Actually, just want to thank the medical board or whoever who's responsible for this. But I just want to thank you for hearing me out about my concerns in the minutes when Black Patients Matter was deleted from any of the minutes. And after I complained, it was put back in. So we greatly appreciate that. Thank you.
Thank you for your public comment. Next request we had here is from Beth Darnell. Beth, you should be receiving that prompt on your. Oh, Beth, here looks like your line's open.
Okay, great. Yeah, I just wanted to relay a message from Dr. Mackey, who said he needs 3 minutes. He's having a technical difficulty, but is working through it right now.
Thank you, Beth. I'll be looking for him to rejoin the meeting, and
great. Thank you.
We'll get back to his item. Thank you so much.
Okay.
Okay, President Lawson, I'm just checking here. I don't see any additional requests in queue at this time.
All right, thank you, Sean. We'll bring it back to the board. Mr. Watkins, were you able to identify and even just a general?
Yeah, it was on agenda item 5.
Okay.
The main correction was agenda item 5, and it was the last paragraph of a statement I made. Mr. Watkins said that he spoke to reporters from CBS Morning News. I just changed the last sentence, and that even though the board is failing consumers and continues to tip the scales in favor of doctors, is what I added. So that will be my only correction.
Thank you, Mr. Watkins. Dr. Hawkins and Dr. Thorpe, are you okay amending your motion to include that correction?
Yes. Yes.
Dr. Thorpe? Okay, thank you. So members, please do unmute your computers, and Ms. Caldwell, please perform the roll call vote.
Dr. Gonadev,
Yes.
Dr. Hawkins,
Yes.
Dr. Helzer,
Yes.
Ms. Lawson,
Yes.
Ms. Lubiano, Ms. Lubiano, Mr. Rue,
Yes.
Dr. Thorpe,
Yes.
Mr. Watkins,
Yes.
Dr. Yip.
Yes.
Thank you. And can I confirm Dr. Mahmood, Mr. Brooks, and Ms. Campoverde are absent, correct?
That's correct. I do think Ms. Lubiano was trying to come off mute there, so she may have a vote to register.
Ms. Lubiano?
Ms. Lubiano, we can't hear you.
Can you hear me now?
Yes.
Oh, that's a yes vote. Thank you.
Thank you.
Thank you. That motion carries. So, Sean, do we have Dr. Mackey back on yet, or should I move on to the president's report?
He's joining now. I just put him back in as panelist. Let's see if he's... Mr. Mackey, or Dr. Mackey, are you able to unmute there?
Yes. How are we doing now?
I loaded much quicker this time.
Yeah. I don't know if I'm the only one out there that has ever been hijacked by Windows insisting they're going to do a system update right when you're in the middle of a important presentation. If anybody else has experienced it, my condolences to you, but it insisted on rebooting and updating. So I'm sorry about that, everyone. Can you see my screen, my slides?
Yes.
Yes, we can.
Yes,
Okay.
coming through clearly.
All right. So I'm going to work to move along and get to the salient points here. So once again, thank you to the board. Thank you to all of you who have joined in today to talk about the issue of chronic pain and solutions for this public health crisis that we have in pain. I think I already gave my introductions. Hopefully that came across. My disclosures, I have no industry disclosures. My position on opioids, which I'll just repeat, which is I am not pro-opioid, I'm not anti-opioid, I'm pro-patient. And I believe that things got cut off when this slide was showing, which was to illustrate the public health crisis of pain that we have in this country and the magnitude of it, which is shown in this slide here, which came about through work on the Institute of Medicine report on pain. Here, we commissioned an econometric study showing that about 1 in 3 Americans, or about 100 million Americans, have some degree of pain. We followed up with another study showing about 20 million Americans have what we refer to as high impact chronic pain. Now, I know there was an interest in talking about intractable pain. Please understand that intractable pain is a term that was used approximately 10 years or more ago with the Intractable Pain Care Act in 2011 that was passed. It lacks a degree of precision when we're talking about it from scientific terms and clinical terms. And I think you could use probably synonymously this term high impact chronic pain to also reflect that meaning intractable pain. And we can talk about that more. Now, the costs of pain, huge, $500 billion per year. I will point out that's more than diabetes, heart disease, and cancer combined when you add all that up. So what else that we learned from this through high impact chronic pain? We define this, and again, we're using this synonymously with intractable pain here, is that pain that has substantial participation restrictions due to pain in work, social, self-care activities lasting 6 months or more. And there's a tremendous amount of research ongoing right now to better understand what are those features that may lead somebody to have high impact chronic pain or intractable pain, and then what can we do about it? Now, what does that mean for the state of California? Well, part of the problem that we have here in California, as well as every other state, is that the quality of data we have is rather terrible. But just doing some extrapolations from the IOM study to the state of California, we probably have about 13 million 13 million Californians with chronic pain. And we probably spend around $76 billion or more in direct and indirect medical costs for chronic pain in this state alone. It's an amazing, astounding number, particularly when we're dealing with a state as large as California. We also put forward the following tenets, the basic principles that while chronic pain is frequently a symptom of a condition, it can become a disease in and of itself. One, very much like diabetes, heart disease, asthma, one that needs to be frequently managed over time, and we don't have often cures for it, but we can help provide people with improvements in quality of life and, yes, reductions in pain. That pain management is a moral imperative for anybody who cares for somebody in pain, that we have severe, terrible disparities in the prevalence and care, disparities across sex, gender, age, race, ethnicity, and geography. We need better, more comprehensive and interdisciplinary approaches for chronic pain. One of the key messages that we see in all of these efforts, once again, is that the quality of the data we need is absolutely terrible, and we need to improve that if we're going to improve the state of pain. We need to treat this as a public health crisis, and I'm going to keep coming back to that, and as such use public health approaches to it. And we need to recognize that while we need more research, we need more knowledge, we actually know quite a bit. And the problem is that we're not getting the existing knowledge in the hands of those who most need it. That means the patients, the people living with pain. That means primary care docs out there, and we need to do a better job with that. We recognized in the IOM pain report the conundrum of opioids, that while for some people they can be life-saving, they can help improve function and quality of life, for others it can be terribly devastating. And finally, we called upon greater roles in collaboration between patients and clinicians. Now, I wanted to make sure the patient's voice was being heard in this, and so I put some quotes that we had through some of these committee efforts at a national level. This one from a patient with a condition called reflex sympathetic dystrophy, or RSD. It's a terrible burning nerve pain condition, and she states here, "We need some form of relief when you can't sit, stand, walk, or even sleep without pain. Life is unbearable. There's no cure, no answers, nothing. We're told we have to learn to live with it. I wouldn't wish this on anyone. I wish researchers could go through this just one day of their life as I live it, as they would understand how devastating this is. At least with cancer and other diseases that have a definitive treatment or an answer, you can look ahead and have hope. There is no hope for people with RSD. Just learn to live with it is not acceptable. Please help us." While we have this public health crisis with pain, we have to recognize that we have an ongoing public health crisis with opioids. And every day we open up similarly media and we see some message around opioids. And I want to give you just a little bit of a historical view. This is a slide that's continually updated by the CDC every year. And what we see here in focusing on these different lines is that the opioid crisis, and we look at the overdose mortality, the overdose deaths due to opioids, was early on driven by prescription opioids, the yellow line, as you see here, from the late 90s until the early 2010, at which point in time things were overtaken by heroin. Heroin then came on and really became a major issue. And then what has happened more recently, the third wave that happened about 7-8 years ago, was this takeoff of the synthetic opioids, the illicit fentanyls that entered our country. And now, and you see in this orange line, have really become the compelling, most predominant issue around addiction in this country. You see actually prescription opioids have either flattened across the country or have actually dropped. Take a note of the y-axis here, and you'll see the yellow line seems to be hovering overdose deaths around 5 per 100,000. I'm going to get into California right now. So it was, I believe, Speaker of the House, Tip O'Neill, who said all politics are local. Well, to paraphrase that, I'll say all addiction is local. We can't treat addiction as an average across the entire country. Different states have different magnitudes of problem with different substances. The state of California never had the prescription opioid problem that West Virginia, Ohio, Kentucky did. I don't want to say we were immune to it, but we didn't have nearly the magnitude of the problem. I will say that we've had a rather dramatic drop off in opioid prescribing over the last several years, as reflected in this graph. But what is interesting about this is that while we've had a drop off in the opioid prescribing, this is California's data for prescription opioid overdose deaths. This is straight from the CDC. This is eliminating the synthetic opioids. And what you see, in over 20 years, it hasn't changed. We have been rather flat, somewhere between 2 to 2.5 lives lost per 100,000 population. Now, we see that when you multiply that by a state as large as us, it's still a big number. But on a rate aspect, it is incredibly lower than many of the other states in the country. And what you see in the lower right-hand graph is that while prescription opioid overdose deaths have been flat for years, we're seeing an explosion of fentanyl-related overdose. And we need to keep that in mind as we're focusing on public health solutions to these problems. Now, this slide here is a rather busy one, and it's my most busy slide of all. And I'm going to go through this quickly. And the point of this is, at least in my opinion and many opinion, we can't pin our finger on one cause for the prescription for the opioid epidemic, that it is ultimately a systems issue that conspired, a perfect storm, if you will, to come together and create the problem that we had. I'm actually not going to read off the bullet points for this. I'm assuming you're reading them off yourself. But one of the key messages here is that it was a systems issue across multiple factors that got us into this mess. And it's going to take a systems approach, a public health approach, to get us out of this mess. One of the most recent factors that was brought into helping explain some of the prescription opioid crisis was by Case and Deaton, who coined the term deaths of despair. These people who were predominantly at the time white and unemployed, coming out of the Great Recession without jobs in West Virginia, Kentucky, Ohio, and turning to prescription opioids and leading to that explosion of problems that they had in those states. So as I mentioned, there was a lot of factors that come into this. And I'm quite fond of this quote by H.L. Mencken, who stated, "Explanations exist. They've existed for all time. And there's always a well-known solution to every human problem, one that is neat, plausible, and wrong," which means that we would be kidding ourselves if we think we can find a single solution to this combined problem of pain and opioids. It's going to be a rather nuanced, complex issue that we're, once again, all going to have to work together on. We all are aware of the CDC guidelines that came out in 2016, all with the laudable intent of improving safety for our citizens. And that intent is clear, meritorious, but unfortunately, shortly thereafter, we started seeing the unintended consequences of the CDC opioid guidelines, reports of patients being dumped by physicians. We saw that rather early on here in the state of California. We saw more and more physicians refusing to prescribe and using the CDC guidelines as an excuse not to prescribe. And more patients feeling stigmatized, invalidated, and unable to find care. It was in just a couple years ago that the CDC finally issued a mea culpa. They issued a guidance and an op-ed in New England Journal of Medicine where they admitted mistakes were made. that they realized that the CDC guidelines were used in ways they were never intended to be used. They have recently gone under revision, and purely coincidentally, this morning, there is a revision to the CDC opioid guidelines that have been released for draft public commentary, and encourage everybody to read that. I'll share that the last version of it that went out and was commented on was excoriated for a number of problems with it, and we're hopeful that the version that was put forward today has corrected a lot of those challenges. Now, I want to pivot just a moment, because one of the questions to me in prepping for this was, can you please go over, comprehensive pain management and what that involves? And the key to this is to take a rather patient-centered approach in the management of somebody living with chronic pain. Recognize that everybody's pain is unique and individual, that everybody experiences pain after an injury, after surgery, differently from somebody else, and that we ultimately have to apply an approach that evaluates them from a 360-degree perspective across physical, psychological, and social functioning perspectives, and then bring to bear the many tools that we have available for chronic pain. Tools that include pharmacologic agents, I'll get to, procedures, psychological behavioral approaches, physical and occupational therapy approaches, complementary and alternative medicine approaches, are now often referred to as integrative medicine approaches, and then personal management approaches, which are gaining a lot of interest throughout the country. I think one of the things that are frequently lost on both clinicians as well as patients is that we now have over 200 medications for the treatment of pain. When I was starting out 20 years ago, we only had a small handful. We had opioids, we had NSAIDs, we had a couple tricyclics, antidepressants, and not much else. But now we've got over 200 of these meds. And what we do is we use these meds to target pain at different parts along the pain processing pathway. And for the docs here listening in, as you look here at this list, you'll see medications that you recognize. And the fact is that in pain medicine, we steal from everybody. We take from the neurologists their anticonvulsants, the psychiatrists their antidepressants, the cardiologists their antiarrhythmics, and we often find that those medications work better for pain than for the original reason they were FDA approved. But what that means is we're often using medications off-label as a consequence of that. We do a lot of procedures in the area of pain. And I'm just giving a laundry list here of some of these, everything from simple trigger point injections, spinal blocks, nerve blocks, to implantation of devices, including neuromodulation or nerve stimulation devices, and drug delivery systems. All of these need to be done in the context of a comprehensive approach to pain. Physical therapy is one of the core aspects of any type of pain management approach, because patients can become deconditioned, debilitated, and we need to strengthen them. We need to help improve their understanding of the distinction between what is hurtful and what is harmful, recognizing that we need to get people moving so that they can be reconditioned, and frequently that won't cause them more injury or harm. Similarly, psychological therapies, highly underutilized, and I would say are currently the hot topic in pain these days because they've been so underappreciated. They work, they're effective. Most of the time, they're not curative. I do see some cures with them. I have appreciated the value that pain psychologists bring. We have 7 of them at Stanford who provide incredible work and work in a team environment. And one of the clear needs, and this was put forward in a paper led by my partner, Beth Darnell here at Stanford, is the global needs assessment for pain psychology, recognizing that we need to train more and get them in the hands of practitioners and patients alike. CAM therapies, as I mentioned, acupuncture, over-the-counter nutraceuticals. Nutraceuticals are agents such as what you'd buy at the GNC or the vitamin shop. There's a number of these over-the-counter agents like alpha-lipoic acid, acetyl L-carnitine, fish oils that actually have good analgesic or pain-relieving properties, have good randomized controlled trials, and are available without a prescription. I put mindfulness-based stress reduction under the CAM property, but it's becoming so mainstream these days, I should probably take it out and put it under more traditional personal management approaches. And what we're learning is that the best way to handle all this is to bundle it together. It is frequently, particularly for the person with high impact chronic pain or intractable pain, that a multidisciplinary comprehensive approach is going to win the day. And you know, the reality is we've now known this over 20 years. The data is solid. The problem is that incentives and reimbursements from insurance companies and the government over decades moved us away from these type of approaches towards incentivizing more giving pills, doing procedures, doing surgeries. And we're slowly starting to see a return of incentives to spending more time with patients and this team-based care. Just a quick moment to talk about what we do here at Stanford. So we are one of the largest academic comprehensive centers in the nation. We have over 30 subspecialty board certified trained faculty there from a variety of different and original specialties, including integration with doctoral level trained physical therapists, complex care managers. We have a strong integration with research and clinical care, and we track outcomes on every person. Now, why am I even mentioning this? The reason I mention this is we're in a blessed environment in this small localized area in Northern California. And there are several other centers throughout the state, and there are some really superb community practice areas. But the problem that we're facing is we can't yet get the type of care that we do to the rest of the state. And that's one of the solutions that we need to put forward, is somehow translate the type of quality of care that we can deliver and other centers can deliver so that it's available to everybody in the state of California. So that gets us to some proposed solutions for this public health crisis of pain in California. And my focus here is really on pain. I will be touching on some solutions that'll help us with the prescription opioid problem as well. But I submit to you that if we address the problem of pain, that a lot of the issues around prescription opioids will also be addressed as well. The sources for these proposed solutions are not coming just from me by any means. They're coming from well-established authoritative sources such as the National Academy of Medicine, the HHS National Pain Strategy, and other types of committees that came together across broad representation and stakeholders throughout the entire country. It included clinicians, researchers, policymakers, as well, in almost in every one of these cases, representations by patients and patient advocates alike. So I want to start with a solution playbook that has been handed to us that if we enact it, will enable this cultural transformation that we need in pain care in the state of California, but more broadly across the country. And this is the National Pain Strategy. This grew out of the IOM Pain Report. We called for in the IOM Pain Report for then Secretary Sebelius of Health and Human Services to create a strategic plan for our country to advance a strategic plan that was made up of short, intermediate, and long-term deliverables. And I co-led this effort. We brought together 80 experts across the country, across the sciences, across clinical practice, and we had a large number of patients and patient advocacy leaders that were part of the National Pain Strategy that developed all of it. We created 6 working groups across the areas of population research, prevention and care, disparities, service reimbursement and delivery, professional education, and public education. And one of the, again, the key messages that we put forward that applies both to the United States, but also here in our great state of California, is that we need better data to understand our problem and to guide action. So I'm going to touch base on some of these recommendations as we put forward as solutions here in California and more broadly. And the first one is all about the need for high quality data. We need a better understanding here in California of the prevalence of chronic pain, and particularly high impact chronic pain, or as has been put forward in some of the documents, intractable pain. How many people have intractable pain or high impact chronic pain? We need to know the answer to that, because we need to be able to devote the appropriate resources to be able to assure that we're caring for them, but also for those who have meaningful but maybe not as high impact chronic pain. We need to refine the way we measure chronic pain in our electronic health records, and we need to develop a better system of metrics to be able to track the changes over time in pain, and also determine what's working for which patient in what circumstance. We've learned that disparities exist deeply in the assessment and care of those in pain. As I alluded to before, disparities across age, race, ethnicity, but also geography and socioeconomic status. As I alluded to earlier, in the Bay Area, we've got tremendous resources for the management, the assessment of chronic pain, but you go literally 50, 60 miles inland into Central California, and there's just hardly anybody there. It's a wasteland of care. And then go up to northern California, and it's just forests. And I feel terribly for these patients who can't get the quality of care they deserve. We need to reduce those disparities. We need to reduce the bias towards patients who have these disparities. We need to get them improved access to high quality, high value care. And we need to improve the communications between patients and health professionals to reduce implicit bias. With regard to prevention and care, what's clear is we need a better understanding of what is actually working for patients and what is not working for patients, and what are the costs associated with it. And for those things that are truly working for patients, we need to stop bickering about paying for it and just pay for it. And for those things that absolutely conclusively everybody agrees, and I mean everybody agrees, doesn't work, let's stop paying for it. We need to develop nationwide, or I will state in California, statewide access to accessible digital pain treatment programs and therapies. And we now have the technology to do that. We've been developing them here at Stanford. We've been giving them away, and we need to make this more available throughout the entire state. And then lastly, in this one, we need to have better standardized approaches to how we assess and measure outcomes in pain. Right now, you take 10 docs, you put them in a room with the same patients, you're going to get 10 different assessments and evaluations, all leading to different treatment approaches. Service and reimbursement is all about the money, which unfortunately is what drives a lot of this. And what we need to do is to better incentivize and pay for high quality, multidisciplinary, comprehensive care for patients. We need to pay for team-based care. And we need to pay docs to be able to spend time with them. So I opened up before and I said, how does the doc who's got 200 people or 1,000 people that just landed in their panel who have opioids, and you've got, 12, 15 minutes to spend, with each patient, how do you handle it? And the answer is you can't. As I alluded to, I've been doing this for over 20 years. I've certainly met Gladwell's 10,000 hours to get proficiency and mastery in pain medicine. And when I see a patient with chronic pain, I'm spending well over an hour with each patient on an initial assessment and at least a half an hour for follow-up. My heart goes out to those primary care doctors that are trying to take care of high impact or intractable pain issues with only 12 minutes of time. And so we need to be able to give the docs more time to be able to spend with patients and tailor the reimbursement to promote and incentivize high quality pain care. And as I put here a little commentary, this was not part of the national pain strategy. We need to remove the perverse incentives that may be leading to inappropriate care. We need to, education remains the cornerstone of these solutions. We need to improve the education of those who are caring at every level for those with pain. And I mean every level, not only the physicians, but nurses, dentists, psychologists, physical therapists, podiatrists, pharmacists. I'm leaving groups out, but you get the idea. And what we've learned is that by and large, pain education is truly inadequate, particularly at the medical education level. The statistics are that the average doc gets about 7 to 11 hours of pain management education in medical school. Now, the average vet gets 40 hours, which means if you're taking your dog in for hip pain, you're doing pretty good. But, you know, the average doc just doesn't get much pain management education, and we need to improve that. Fortunately, there are efforts underway being led within here, this great state of California, by Scott Fishman at UC Davis and others who have done an environmental scan of the needs and have put forward proposals on what we need to do to improve professional education. And the second objective here was to create a pain education portal, a centralized area where docs and others can turn to get high quality, reputable, trustable information on pain management. And then finally, last but not by any means least, from a public education standpoint, and this one was particularly driven forward by the patients and patient advocates on the National Pain Strategy, was to develop and implement a national public awareness and information campaign about the impact of pain and taking chronic pain serious. And, you know, my compliments to those that were on that working group for getting this objective put forward. So that was the main objectives and solutions put forward by the National Pain Strategy. That was released in late 2016 under the Obama administration. And then unfortunately, with regard to implementation, it died on the vine when the new administration came in. We're hoping that with the current administration, we can get some traction on it and start doing implementation. But I submit we shouldn't wait. We can put many of these into play in the state of California if there is a will and if there is a coordinated effort to do so. I want to pivot now and comment on something I brought up repeatedly, which is the need for high quality data and high quality evidence for pain. Right now, throughout the entire country, particularly California, the quality of data, again, is terrible. And what the National Academy, recognizing this across all of healthcare, by the way, not just pain, all of healthcare, put forward a 12-part series called the Learning Health System. And a learning health system are software platforms, informatics systems, where what we do is we bring together scientists, clinicians, patients, administrators, where we're collecting high quality evidence, high quality data on people with, in this case, pain. It could be any medical condition. And we're using that data in real time at the moment. We're learning from it. It's continually evolving. It's adapting. We're bringing in new information into it. That's the learning healthcare system. And the reason we need these is because we had pinned all of our hopes on the electronic medical record as our savior. And it turns out it's failed us all miserably. I probably don't need to get a show of hands for those of you who feel the EHR has been the bane of our existence. We all know it. It was never meant to really help improve our ability to care for patients. It was meant to bill patients, to schedule them for procedures in laboratory. So we need these secondary platforms. And I think many of the hospitals and institutions are waking up to this. About 10 years ago, I set forward and built a platform to do this thing. I've been collecting data for 20 or more years and saw the problems. And I wanted to put forward a solution. So I did with a platform called Quorum, which used to be an acronym, but now it's just a standalone. And it's an open source, free, my favorite four-letter F word, free platform for a learning healthcare system that we use at Stanford. It's used in other academic institutions in the US, Canada, and Israel. And it's used to collect high quality evidence on patients that we use at the point of care visit. We collect a large amount of information across physical, psychological, and social domains of functioning global health. We get clinician information integrated into it. We use it for patient education, and we use it to help determine the next steps in treatment. We have integrated into clinical workflow. We use computer adaptive testing to reduce the patient burden because patients are just incredibly overburdened with having to fill out surveys, and this reduces it by about 75%. We can give targeted delivery of educational content as well as targeted digital therapies through it. And it has fundamentally changed the culture of how we care for patients because it's no longer based on our opinion, but it's actually based on data that the patients are delivering to us on what's important to them. So my next recommendation here as I'm going through some of these solutions, and this is one that comes up frequently in our field, is please let us not conflate pain and opioid addiction. Far too frequently, they are discussed in the same breath, as if every person with pain is also an opioid addict, or that every time we talk about chronic pain management, we have to bring in addiction. And unfortunately, and I'm sorry to say, it's just not the case. We, again, are one of the largest centers in the state of California, and it is a very rare patient who shows up in our clinic who truly meets criteria for addiction. We need to separate these concepts. We need to recognize there is some linkages, by the way, but let's not conflate them and treat them as one and the same when they clearly are not. Aligned with that, another recommendation is let's recognize in the state of California the 3 different types of opioid prescribing clinicians. And if you'll allow me a somewhat reductive approach to thinking about physicians in the state of California and nationally, 1 million US physicians, when I looked it up, about 115,000 California physicians. We have 3 broad groups. We have the group of patients, we have the docs that represent the vast majority of physicians in the state of California. And these are docs who are good doctors doing the right thing for the right reason. We have a second group, which is much, much smaller. And this is not to scale, but you get the idea. These are doctors that are doing the wrong thing around opioids, but they're doing it for the right reasons. They're trying to help their patients out, but they're just not doing it the right way. And then a very tiny sliver of doctors at the top that are just plain bad doctors doing the wrong thing for the wrong reasons. These are your pill mill docs. These are the docs that are breaking the law. They're trying to make money off of the system. And what we need are different solutions for these 3 cases. For that tiny sliver of docs out there that are just plain bad, we need to take away their license. And if they're breaking the law, they need to go to jail. That next group, which is larger, but still small, the docs doing the wrong thing for all the right reasons. Here, we need to educate them. We need to train them. We need to give them incentives to do the right thing. We need to help them change their systems to be able to do the right thing. And then we do need to monitor to make sure that these approaches are in place. But I want to make an appeal for the good doctors doing the right thing for the right reason, because for them, what we need to not do are put more draconian policies and procedures in their way to obstruct them from caring for patients that, they're working really hard to provide the best care possible. We need to leave them alone, provide support and encouragement. Now, a talk like this wouldn't be complete if I didn't touch upon the issue of opioid tapering, a hot topic right now across the country and even in the state of California. And this one is incredibly controversial. What we have learned from the data is that there is no good data. There is 0 good data how to guide opioid tapering. We spent many years ramping patients up on opioids. We learned how to ramp them up, but we never learned how to safely, compassionately bring certain patients down. And I'll say that again, certain patients down. What we have learned is that a lot of the early guidelines that came out around opioid tapering were far too aggressive and had unintended consequences. I want to thank Dr. Darnell for sharing a couple of these slides with me. She is our resident expert at Stanford. She is a psychologist, scientist. She's our expert in tapering, and I'm going to touch base on her work more in a moment. What we have learned is that reducing opioids carries risks. So we think that by reducing opioids that we're making the patients better, but in many cases, we might be destabilizing them and actually making them worse. So what we have to do is, if there is going to be an opioid tapering, it needs to be done in a patient-centered way, and we advocate in a compassionate and voluntary way. This is another slide that illustrates the challenges that we have seen with tapering done too aggressively and in a forced manner. Patients ending up with severe withdrawal symptoms, distress, and even patient suicide as a consequence of this. And so this is becoming more clear from a societal standpoint. Dr. Darnell studied this in a community setting in Colorado and published this in JAMA Internal Medicine a few years ago, in which partnering with community physician, they voluntarily, compassionately wean down patients on opioids. And the results of this, you can see here in the green dots, is a number of the patients did in fact successfully wean down, and their pain with that also in many cases reduced, but not always. Some of the patients weaned down on opioids actually got worse, and a number of the patients actually failed in that approach. What was learned from that is that to be successful, these patients need help and they need support. So what Dr. Darnell did was to apply for and successfully obtain a large multi-state grant from PCORI. PCORI is like the NIH. It's a quasi-governmentally funded organization that does pragmatic research that is in the setting of clinical care. And this is a comparison between usual care, cognitive behavioral therapy approaches, and chronic pain self-management to help aid people voluntarily and compassionately wean down. And for those who are listening, I want to emphasize voluntarily wean down. Nobody is being forced in this study. Nobody is being forced in this study. The patients are working collaboratively with their docs to wean to a lower level. This weaning doesn't mean wean to off. The reason I bring this up is because we have a prepackaged plug and play approach for the state of California for those who want to engage in it. The systems are already there and ready to go, and it's a tried and true method. She's done an incredible job of building up this infrastructure. We capture data on every single patient and track them over time. And the purpose of the tracking is to help them. So we find that, for instance, this patient on the left, I'll just interpret this for you because it's a little bit of a complex data side. The patient on the left, while coming down slowly on their opioids, that's the dots here, we find that their pain really didn't change. And they did show improvements across sleep. They had reductions in social isolation. They had reductions in fatigue. They overall got better with the reduction. But you know what? The patient on the right had a lot more variability in their pain. The pain went up and down with the reduction, and it was a much slower process. And on top of it, I'll just give you the soundbite on the right over here. Their cognitive functioning got worse with the opioid tapering. And so what we need to do is make sure that we're monitoring and working hand in hand with each patient throughout this process. And if you want to learn more about it, empower.stanford.edu. So I want to close out on the tapering also to make a point. The tapering is not right for all patients. It is not right for all patients. It is taken on a case-by-case individual basis. We need to recognize that tapering may increase health risks unless the correct methods are done. They need to be monitored carefully, and it needs to be done in a compassionate, patient-centered way. Another quote that came out of the IOM pain report with patients putting in their commentary: I don't know of any other condition in which that is the case. Why is it okay with pain patients? Is it because our pain is invisible and unquantifiable? We're not all drug addicts. We're not all criminals. We're suffering needlessly. I haven't done anything wrong. I've suffered so much at the hands of doctors who are supposed to be helping me. Where is their compassion? How much can one person endure and still be expected to handle it with grace and dignity? And this is some of the challenges that we're facing, and we need to work to build better rapport. I'm closing out here on some of the final recommendations here. One of the major recommendations from the Iowa report was to support greater collaboration between specialists and primary care docs. But in doing that, I'll share with you that we have a problem in this state in that many of the physicians are working in fear of the medical board and the Department of Justice and the DEA. And they're in fear that the medical board is going to come down on them around their opioid prescribing. I have 24, 25 physician faculty at Stanford in pain. Every single one of them, except for me, is scared of you. I think in my talking with you, you're all kind, compassionate, rational docs, but they just keep hearing these stories externally about the medical board investigating this doctor and that doctor. And as a consequence, they're fearful of taking on patients who may be on opioids. I know that's not what's intended, but I think there's an opportunity for a public relations campaign, because I am convinced that you are actually out there to support doctors. And I'm actually convinced that you're out there to support optimized healthcare for the people in the state of California. I mean, I know it in my heart, but we need to get the word out so that the docs can feel comfortable practicing in the way they want in this space, deliver good care and not do it in fear. Finally, we need to improve access issues around telemedicine and advocate that continued funding levels for telemedicine are encouraged when COVID ends. And as we're developing guidelines and policies, we need to take a more rational approach and be aware of the unintended consequences of binary absolute thinking that has occurred with many of these other guidelines. And I've learned over the last number of years to be more and more inclusive and include the patient voice in those guideline development. Finally, to the patients on the line and the patient advocates, I am reminded of this quote from Margaret Mead, who said, "We are continually faced with great opportunities which are brilliantly disguised as unsolvable problems. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." I have been impressed with how patient advocates have worked effectively. And I particularly want to note those that I've had the pleasure of working with, the Chris Veasleys, the Penny Cowans, the Andrea Andersons, and others that have worked to collaboratively work with with physicians and patients and represent them well. And just give my thanks to them. Finally, my last slide, our dream, our vision from the National Pain Strategy and what we want for the state of California and the country as a whole, that we want Americans to recognize chronic pain as a complex disease and a threat to our public health, that significant public resources would be invested in the areas of preventing pain, creating access to evidence-based and high-quality pain assessments and treatment services among those who live with pain, and that individuals who live with chronic pain would be viewed and treated with compassion and respect. With that, I want to close out. I know we had a little bobble with the tech, and don't know where we stand with time, but I'm delighted to answer any questions you have around pain. And thank you again for inviting me.
Dr. Mackey, thank you for that excellent presentation. I can share with you that as the daughter of a mother who has lived with chronic pain for over 20 years following a devastating car accident, it is extraordinarily helpful for me to have heard your perspective. And then from my perspective as the president of the medical board, this has been an issue that many of our advocates, many of those who come speak to us at our quarterly meetings have been interested in. And so I'm just grateful that we had the opportunity to hear from you and to have you share the information with the public. Are there members of the board that have questions for Dr. Mackey? I've got Dr. Gananadev first and Dr. Helzer, I'll come to you second.
Dr. Mackey, thank you. Thank you for presenting, and your just a statement-wise, I think I agree with your statement that many primary care doctors are afraid of the medical board. This is actually coming from a medical board member for 10 years and past president. So I heard many members basically saying, we have this tendency, if we get one reason or other, then we go through the entire Pierce report and we come up with what they haven't done in managing pain. Yeah. So unfortunately, the CDC and our guidelines made us to do that. But my question is this: I mean, interestingly, there is so much. You are in the technological capital of the world. I mean, recently, I think just a few days ago, something like transcranial magnetic stimulation treatment for depression came.
Yeah.
Why not something for pain? Because it's, in the end, pain is electrical impulses going to the brain and brain responding. So I'm just curious, is there any research which is somewhat close to helping most of these people without drugs, without other stuff?
Yeah, thank you for, there was 2 points there, one about the medical board and which you brought up, and the other about transcranial magnetic stimulation, addressing them both. And just to emphasize, again, I think you guys are great. And I think what you're doing is a great civic responsibility and service, and you give a lot of time. And I think you're getting a lot of bad PR, and I think we need to work together to improve that. And candidly, it's for self-serving purposes, because if I can get our docs to stop being scared of you, they're going to start, you know, just relaxing and providing the care that they need to do. And I think it's rather straightforward to do it. Well, it's simple, but it may not be easy. Secondly, yeah, I study TMS. So transcranial magnetic stimulation involves an external magnet, non-invasively. It zaps the brain. I've published some papers on it. We've looked at mechanisms of it. And here's the deal. And this is a point that I think it's worth driving. 200 medications, 200 procedures that we have, multiple psychological approaches, physical therapy approaches, and yes, transcranial magnetic stimulation, and there is no magic bullet. I get some patients, but it's a small sliver, who I hit the ball out of the park with TMS. But it's only a small number of people. That's the frustrating thing that I have to explain to patients, is it's not like we open up a textbook and we say, you're definitely going to respond to TMS or this particular drug. So it's a very frustrating trial and error process. It's getting better. We're so much better than we were 20 years ago. But we're working to refine TMS for pain, and I'm optimistic it will serve as one additional useful tool.
Great, thank you.
Dr. Helzer.
Dr. Mackey, thank you for your presentation. I'm curious if you could comment on the board's guidelines for prescribing controlled substances and their impact on pain management in California.
I'm very happy that it's being revised. I think a lot of these guidelines are overdue for being revised, and I think the board recognizes room for improvement, or they wouldn't be getting revised. And in full disclosure, I've been asked to play a role in that revision. Here's my, if I may make a recommendation and a plea. It's sometimes the easy way out just to accept, in this case, like whatever the CDC puts out for their opioid guidelines, and say, we're just going to adopt the CDC opioid guidelines. I strongly implore us not to do that. I haven't seen the current draft. It could be the greatest thing since sliced bread. The last version I saw not so good and very concerning. And part of my concern around the current CDC guideline development is its lack of inclusivity. It was written by one academic outcomes doc and 4 or 5 CDC scientists. No patients on the group, no pain experts on the group, and it's a technical document. Will it apply to the citizens of the state of California? I don't know, but I think we need to put forward the best set of guidelines for our state possible. And I'm committed to helping the medical board do that.
Thank you.
Can I, Mr. President? Christina, I just want to make sure I'm in the queue. Randy.
Sure, I have, Mr. Rue next, and then Dr. Hawkins.
Thank you, Dr. McKay. That was a great presentation, and I was actually really looking forward to your presentation as a non-doctor on the board. I have 3 questions. I don't know. I'll ask them separately. First question is, you talked about the prescription opioid abuse being down while illicit drug use going up. Can you kind of expound on that a little bit more, not just nationally, but more in particular for California? And so should we no longer, at least in California, worry about prescription opioid abuse?
One, yeah, the fentanyls are just exploding, and you could see it. It was a wave coming from the East Coast, and it was inevitably going to hit us. I gave the same message to the state of Oregon when they're putting so much interest on prescription opioids, and they had a 5-fold increase a couple of years ago in fentanyl. And I said, folks, this is going to blow up in your backyard, and this is where you need to start putting attention. Should we stop worrying about prescription opioids? Clearly not. And again, this is where we shouldn't get into binary thinking. It's a nuanced issue, but it needs to be put also within the perspective of the magnitude of the problem. Right now, the magnitude is really these illicit fentanyls. And, we need to have good guidance on how to prescribe opioids to the right patient in the right circumstance, and make sure that we don't otherwise. And I should make mention, I didn't in my introduction, that, I've written a lot of patients for opioids, and I've taken a lot of patients off opioids. It's just a tool. And it's got to be used in the right context of a, rehabilitative process to help people get better. It was a little bit of a long-winded answer to your response. Were all 3 questions bundled in that, or was that question 1?
No, that's just question 1. So that's a good enough for me. Second question was, you talked about some of the solutions, removing perverse incentives. Can you kind of expound on that a little bit, and what current incentives there are, and about that?
Well, I think the primary care docs experience this all the time. There's incentives to just getting people in and out. It's production pressures for just seeing large numbers of patients, which unfortunately incentivize docs to just write a pill because a pill is easy to prescribe. It takes a lot of time, to really understand a person living with pain. You have to listen to their story. That takes time. Our systems are not incentivized to give docs time. And that's what I'm alluding to, is let's incentivize to give the best quality care possible and not just break out a prescription pad. And let me be clear when I say prescription pad, because everybody always translates that into opioids. As I said, there's 200 meds. It could just as easily be a prescription pad for a duloxetine or a gabapentin or an NSAID or what have you. We need to better incentivize the things that's needed for the complex care of these patients.
Okay, now this is the hard question. I don't know if you'll have an answer for this, but I'm fairly new to the board, and I'm a non-physician. So anytime I get any kind of cases with opioid prescription abuse, I don't know where to go. I'm at a loss. And you were talking about how to identify the pill mill docs, right? And that's exactly it. And there's a lot of resources to us. There's those guidelines, and the most important thing is the often expert testimonies, which are of course always conflicting. So it doesn't really help. What for a board member here who is a non-physician, what resources do I have, or how can I gauge what's a abusive prescription doctor versus a good doctor trying to help their patients? And obviously I have limited information in front of me as well.
Yeah. I have a simple answer, but it's not easy. Can I call you? Is it okay to call you David, or do you prefer Mr. Rue?
David's fine.
David, I'm Sean. And David, my simple but not easy answer is, unfortunately, you need to get more educated about the language of addiction and pain management. And it's not easy. One of the recommendations I was going to put into my talk, which I couldn't fit it in the time, even talking as quickly as I did, is we need better precision in our language around addiction and opioids, because right now we have a lack of precision, and the terms get misused and even weaponized against docs and weaponized against patients. You used abuse, the term misuse of opioids. What does that really mean? Depending on who you are and what lens you look at, you know, you've got 30 to 40% of patients misusing their opioids. The other lens suggests, no, it's only a tiny percentage. It depends on the way you define the term. You've heard the term, David, opioid dependence, perhaps? Well, if you're an addiction medicine doc, opioid dependence is often frequently associated with addiction. But if you're a pain doc, opioid dependence is simply a physiologic consequence that occurs with 100% of people on opioids. It just means they develop a degree of physiologic tolerance to it. It's the same thing happens when you put somebody on a blood pressure medication and you take, you know, they get dependent on it. And it has nothing to do with addiction. And we're recognizing that our imprecision in language is causing real problems. You've heard the term OUD, opioid use disorder. Opioid use disorder is treated as a binary diagnosis. You either have it or you don't. The DSM-5, it's not a binary diagnosis. It's a spectrum, none, mild, moderate, or severe. And yet we treat everybody and lump everybody as you've got OUD. It's incredibly inappropriate and very imprecise. And so, David, my message to you is, unfortunately, you got a tough job. Guy, you got a tough job. Try to get as educated you can on reliable sources of information.
Could you maybe, just quick follow-up, can you maybe give some recommendations for some educational materials or reading materials? Again, I'm a non-physician, because the only backdrop I have are those, you know, horror stories and documentaries that you see about opioid abuse in the various news outlets, and
Yeah.
obviously the extreme side. So I would really like to, obviously not having any pain, I don't understand the magnitude of this pain, right? So if you could recommend offline some reading literature or documentary or whatever it is that I could get more educated on.
Delighted to help you with that.
Thank you.
Really.
I think Dr. Hawkins, excuse me, you're up next.
Yes, thank you. Thanks, and Dr. Mackey. Randy Hawkins, I'm a physician in private practice over 30 years. So I have some of those patients we're talking about. Comprehensive presentation, but what I'd like to know is what would you recommend to me and to the medical board about information you should give to the doctors like me that are practicing and taking care of these patients? You mentioned a digital item, you mentioned pain education portal, you mentioned learning health systems, National Academy of Medicine. Where do we start for me and for the board to give to other physicians who are interested in this? And I also want to make sure that we give time to our public, many people who are interested in this topic. So Chris, you may need to make an adjustment.
Well, Dr. Hawkins, you know, candidly, part of that broad policy stuff I appreciate is outside the purview of the medical board and falls into like Sacramento. And, you know, my hope is that maybe people are listening and we can engender resources and all come together to help make some of those things happen. For the primary care docs out there, you know, let me ask you, Dr. Hawkins, you know, can you do something as simple as when you have Mr. Smith or Mrs. Jones, who's on a large amount of opioids with chronic pain, do you have the ability simply to schedule people for a double visit, you know, like twice as much time or 3 times as much time and bill a higher level code? Or are you like precluded where you only have this tiny little bit and that's it? That's what the rules say. Because I think the main thing is it's time and listening, and then also it's working collaboratively with your specialists. So learning your local community resources and what pain specialists are there. And, you know, let's face it, there's a spectrum of pain specialists. There are those that practice in a very unimodality means, and we all know what that means. And there are those that practice in a more comprehensive approach. And it's learn where your resources are. One of the nice things, one of the only nice things that came out of COVID is that it's allowed our telemedicine reach to cover broader areas of California that we could never do. So I think what we all have to do is work with you and the other primary care docs in a collaborative manner to help you get your needs met.
That response is helpful. I'm not going to ask for more than that, and I'll look at your resources.
Thank you.
Additional questions from the board before we go to the public? Ms. Lubiano?
Dr. Madam Chair, This is Dick Thorpe. I'm sorry. I just wanted to thank Dr. Mackey. Sean, I think you did a great job. It did really speak to the issues that we were concerned about. And I want to thank you very much well, I've got horror stories and all kinds of stuff to tell too, but I don't want to take the time to do that. So I just want to say thank you.
Well, Dr. Thorpe, thank you very much. And, in listening to you before this meeting and hearing you, what came across was you are one of those really compassionate docs that's very deeply thoughtful about this issue around pain and opioids. And you're faced with real challenges in your practice that are not unlike what many of the other primary care docs are doing. And I just want to applaud you because when we chatted, I just thought you were incredibly balanced and deep in your thinking. And thanks for the invitation to come and chat.
Dr. Mahmood, can I intervene a second?
Dr. Mahmood, and then Ms. Lubiano will be next.
Yeah. Thank you so much, Dr. Mackey. Such a wonderful presentation and your service for the last 2 decades or more. What we see is pain has become really the most important issue in medical practice, whatever you do. Yeah. Small city, big city, village, metropolitan area, higher socioeconomics, lower socioeconomics, this is the worst thing.
Yeah.
And we have seen that over the last 30, 40 years, we make the plan for management for hypertension or asthma or COPD or cancer. We see new guidelines come, and every 5 years, we are making some progress. We're controlling blood pressure today better, diabetes today better, asthma better, other cases. But with the pain management, I see the problem is getting worse and worse and worse. All these fancy presentations, most of the people in communities don't have the availability for them. All they have is few pills, and maybe they can go get physical therapy. Other than that, either the things are not available or they don't have the resources. They have that kind of insurance, they are not qualified. Yeah. And we need to come up with, because more people are going to die, more people are going to get crippled if we just make a whole guidelines and protocols and punish these doctors and blame these patients. But if we don't see what the outcome is, why things are getting worse or get to the bottom of the problem, we are not going to be able to control problem. And honestly, I'm in medical practice myself, and I see pain patients, and I basically try to get them to pain management doctors because everybody in the community is a little concerned. Yeah. So is there a way that we can figure out, or our medical board or state of California or anybody can figure out, okay, we need to make this protocol, bring it to everywhere, smaller cities and bigger cities, not only university hospitals, and keep a follow-up after 6 months. What are we doing better? After a year, what are we doing better? Or where our issues are, and how we can save people, or how we can make people more functional. It's really disappointing where we are right now. Unfortunately, I'm being too honest.
Yeah. Wow.
Thank you so much.
No, wow. You captured like so many salient points, and candidly, it ties in, I think, with a lot of the solutions that I put forward. Again, when I say I put forward, I didn't invent these solutions. They were put forward by a lot of people in these efforts. So first, let me address one point, several of these quickly. Chronic pain, folks, it's only going to get worse. And what do I mean by that? I mean, the prevalence is only going to get worse. Why is it getting worse? One, we're getting older and we're living longer. And that's because we're a victim of our own success, everyone. We're keeping people alive longer. And as a consequence, we're living longer, but we have chronic pain. Two, we're keeping people alive after surgery, after injury, after war, motor vehicle accidents that would have used to have died in the past. Now they're alive, but they've got chronic pain. Three, we're keeping people alive after cancer. Our handyman up here, has been sharing with me, he had cancer, he had chemotherapy. He's got chemotherapy-induced neuropathic pain. He can't go walking or hiking with his son because his feet burns. And he would have died otherwise without the chemotherapy. So all of these things are a consequence of the miracles of modern medicine. It's working, but a consequence is we have chronic pain. So it's only going to get worse. We have to come together and find ways of addressing it. And then the things you mentioned, one, you mentioned tracking and understanding. That's where we need better quality data. And we need to, develop those metrics and integrate those into our systems, whether it be our EMRs or learning healthcare systems. Two, you talked about disseminating knowledge, and I brought that up. We have a lot of knowledge about pain. We need to get it in the hands of people like you and others that are working in the trenches. And more importantly, I submit to you, we need to help educate the people living with pain better. We need to help them. What we've learned is one of the key indicators of poor pain outcomes is poor health education. Those who don't understand their own bodies and really what's going on don't do as well. So you brought up a lot of salient points that all kind of taps into and lends themselves well to a number of these solutions. And thanks for raising it. I appreciate your candor.
Okay. Additional questions from board members before I go to the public? Oh, sorry, Ms. Lubiano, you were up next.
Thank you. And thanks, Doc, for the presentation. I think one of the takeaways for me listening to you speak is that this is a multifaceted topic that we, and I say we meaning all, have to attack from different angles. So getting really practical to us at the medical board and what is in our power and capability to do, what would you say are, kind of the top things that we should prioritize, be it, speeding up getting our recommendations on what those guidelines are, or, advocacy in Sacramento? Can you help us prioritize what we can do?
Yeah, thank you for that. Thank you for that. And I'm going to tell you that's a question that deserves a lot of thought. And I'm going to give you just my off the cuff responses, okay? And if I'm going to end up thinking about this tonight, and I might have a different list, so just bear with me. One, I don't think you want to speed up the development of guidelines, and you don't want to sacrifice quality over speed. You want to do this the right way and be thoughtful about it. And I got the sense the board is working to do that too. I don't know if it's magical thinking on my part to imagine a communications campaign or effort from the medical board to docs saying, we're not out to get you. We want you to practice medicine in the best way possible. And if it involves prescribing opioids, if you do these following things, we're not going to harass you. And to help the docs in our center and many others not be afraid of you. And then 3, I like what you said about advocacy on Sacramento. It's a good time to be going after healthcare there, and pain is a huge public health crisis that, number one reason why people are out of work, and huge costs associated with it. And I'd like to see California take a leadership role in this space. Many other states end up following our lead, and we have the opportunities, we have the resources, we have the critical mass to bring together. We'd love to see the leadership from Sacramento with that.
Thank you for that.
Thank you.
No further questions.
Thank you. Other questions from board members? All right, thank you. I'm going to have Sean open it up to the public so that they can provide comments. And Dr. Mackey, just for your benefit, typically, because of our rules, we don't permit back and forth during public comments. We receive the comments. And Carrie, correct me if I'm wrong on that point, but I think that's correct.
That's correct.
So Dr. Lawson, just to be clear, I should just shut up and listen and not say anything.
I think that's right. And just one correction, I'm not a doctor either. So.
Oh, okay. All right.
Sean, do you want to open it up for the public? Or Sean may be gone now. It may be Angel. Thank you.
Yes, that is correct. So I'm going to go ahead and open up to Kristen Ogden.
Thank you. I'd like to start by thanking the board for following through and providing this presentation to your members. I have been one of the advocates requesting that the board receive such a presentation, and I think Dr. Mackey was an excellent choice. Thank you for doing it. I appreciate that all of you seem to have appreciated it, and Dr. Mackey would say to you, even though you can't respond, that I do appreciate it as well. I noticed a number of particular things that I thought were very, very important. I will start with one that's just informational. I commented on the National Pain Strategy when it came out, and I was concerned about the definition of high impact chronic pain. Not that I disagreed with most of it, but as part of the descriptive information, there were statements that it amounts to pain with remissions, but frequent relapses. In my experience with my family members and others, and I do use the term intractable, intractable pain is constant. It has absolutely no remissions. I think that kind of label only applies to a very small percentage of very severe pain patients who have been ill for a very long time. But there are people who don't have any remissions. I appreciate that you made the point not to conflate pain and addiction, that you explained dependence. These are very, very important concepts that are too often misused, misstated in the media. I would very much agree with any kind of campaign to educate doctors, but also to educate the general public. The family member who is of most concern to me, we both feel and have felt for a very long time the occasional sting of the stigma. And we are not bad people. My husband's not a criminal, never did a thing wrong, and didn't deserve this pain. He is almost 72 years old, and he's been in pain since he was 6 years old. So he has lived with these issues. And even though we have tried many, many, many treatments, nothing really solved his problem to an acceptable degree other than opioid pain medications. And I think he's maybe one of a tiny, tiny fraction of the population. My point would simply be that people like him deserve considerate, compassionate care and not to be treated in a stigmatized fashion. I agree, and thank you for saying that to understand a person's pain, you have to listen to them. Overall, sir, I thought your presentation was good. I just point out a couple of things that I had thoughts about. Once again, I'll go ahead and conclude and say I appreciate the board's act in bringing the presentation and the fact that you all have attended to it very, very closely. It's obvious. And Dr. Mackey, thank you for making it. Thanks again for the opportunity to comment.
Next, we have Susan Lauren.
Hello, can you hear me?
Yes.
Can you hear me? Okay, thank you. I thought this was very interesting, and I want to thank the board for putting this on and for the doctor for such a good presentation. I'd like to offer my experience. I was a licensed massage therapist and cognitive behavioral therapist for over 25 years, and I have well over 30,000 hours in the field. As we're talking about pain, I kept wanting to hear the term massage therapy, and my outcomes with my clients were excellent, both in maintaining health and in managing pain. And it's confounding to me that the medical field sort of takes over what's going on with people's health and bodies. And the only reason I stopped my career was I was taken out of it, as you know, by medical harm. And I miss it terribly. And when, doctors used to refer to me, and I would work in tandem with them. And the fact that people can't get coverage and generous coverage. I understand people go to physical therapy, and that can help, and it does help a lot of people. It's often not enough. And massage in itself, a whole massage session is different than physical therapy, which of course I support physical therapy. But I mean, I would say you ask what you can do, my suggestions for however you'll listen to them. You could pass legislation to cover massage therapy as an ongoing means for wellness and pain management. And quite frankly, I don't know why that wouldn't be done if we really want to take care of people's health. The other thing is listen to patients, as has been mentioned, and don't classify them as having somatic or fictitious disorder. I saw this throughout my career, and people would come to me, and the first way that they would begin to heal, and not everyone can heal, and sometimes, it depends on the source of the pain or whatever, but if I could just communicate how excellent the outcomes were. But so many people came and they said either their family members or their doctors were telling them it's in their head, they're not thinking about things right, they're just being, it's the whole thing. And by the way, after the surgical harm, this is what I ran into with most everyone. And all it does is compound the problems, and it's not good. So I'd like us to take a whole different look at people with pain. Oh, okay, the other thing is stop medical harm, obviously, and because that's causing a lot of pain, and we really need to focus on that. When I went to a neurologist after the Berger did this to me, he suggested 3 things. 1, opioids, 2, acupuncture, 3, swimming. Well, I get massage therapy once a week. It can't heal me because I have chunks of my body missing and deep structures harmed. But the massage therapy, if that was covered for me, and I am in intractable pain, that would help. The only the only medication. Okay, am I done? Did I use my time? Okay, well, anyway, I appreciate the time. Thank you.
Thank you.
Next, we have Andrea Anderson.
Shout out. I just wanted to offer to the question about the medical board making recommendations. The state of Texas, president of the medical board is Dr. Sharif Zafran, who is also was on the HHS task force, and he wrote a letter to all of his physicians in the state of Texas, letting them know how guidelines would be interpreted and what was considered safe prescribing in the state of Texas. I just wanted to offer that letter to you all. Dr. Mackey, I emailed you a copy of it if you wanted to share. It put the physicians, it really helped them understand what the parameters were, what was safe, what wasn't safe, and it kind of relieved a lot of the anxiety around taking care of patients. So I just wanted to offer that to you all.
Next, we have Dr. Reed.
Yes, hello, Hannah Ree here with Black Patients Matter. So Dr. Mackey, very much enjoyed your informative presentation, and we thank you for utilizing the terms such as implicit bias, disparities, diversities. And so we feel like we've been seen, so greatly appreciate that. I would encourage you, as well as any other physician in the state of California, to list on your resume that you have worked in promoting diversity and in acknowledging the diversity and seeing patients from diverse backgrounds, and that you don't just work in a clinic that only sees a single race or ethnic group of patients. Because as some of you may know, we're advocating for medical experts and consultants to be to have significant recent work in diversity, to be able to be contracted with the state of California. And also, you had mentioned, the sphere factor of the Department of Justice sort of thing. And that goes along with the point I made in the beginning, is that we have a serious concern about the lawyers actually diagnosing patients and interfering with patient care. And so that's quite intrusive. It's not so much a warning to stay in your lane as much as it is having someone practice medicine who is not trained to do so. So I'm it's starting to feel like that's what we're arguing here. And I'm well, I don't mind sharing with you again that we have a federal civil rights lawsuit against several California AGs, and it looks like the courts are going to agree with us that, you know, as a lawyer, you cannot practice medicine. Thank you.
All right, thank you so much for that. Next, we have Virginia.
Hello again. Thank you very much for the excellent talk. I really enjoyed it. I read a lot of the disciplines, and a lot of times it says the same thing. Didn't do urine testing, didn't properly document, didn't do plan of care, had no referrals. So I'm also wondering, do the doctors know the guidelines for that? Well, sometimes it's excessive. It seems like they don't even know this basic information. I was a chronic pain patient for 3 years, and I can tell you that I took over 130 doctors or medical professionals to fix my pain. I had 50 pelvic exams by 20 medical professionals, and only 2 of them properly know how to assess a pelvic floor. While pelvic floor pain is very prominent, like a lot of women have it, and nobody knew how to properly assess it. Finally, a doctor in Arizona, 15 minutes, and I've been out of pain since 2013. I couldn't sit for 3 years, 20 injections for pain. I developed PTSD from it. The doctors don't know anything about PTSD, how it changes the voice, how it affects communication, how it affects the regulation of the stress response. They're not trained in that, and they keep on asking for training for that, and they don't do it. They also don't know the suicidal risk of the medications they give. I was on probably 20 medications with suicidal risks. I kept on saying these medications are affecting me, and they blew me off. I stopped all my medications. I went to get trauma therapy, and I'm much better. So it's really concerning that they don't have the basic education. I just spent like 30 minutes talking to my congressman about this. They don't understand trauma. They don't understand pain. They don't understand suicide risks. And these are the people we're going to help. They're often labeled with anxiety and depression, with is actually often trauma underneath of it, and trauma therapy would help. And also things like isolated stretch helped me a lot. And I also had adhesions down my legs. And once we fixed the adhesions, after everything else, significant pain relief. No medication, just taking away the adhesions. And I just became in incredible pain in the last 3 days. I've been to 3 doctors. I spent over $400 in between x-rays, going to the doctor, getting all these medications that didn't help. Finally today, I got Toradol injection, which helped, and gabapentin, which helped. But for 2 days, I was like in incredible pain with no relief. So it's very frustrating. And after having like PTSD from pain, you think it would be like, I'd really take care of this patient. And it's the same stuff over and over again. So we really need to have doctors trained in trauma, the suicidal risk of all these medications, how to assess pain, how to assess pelvic pain, and which a lot of that was talked on earlier, but the suicidal risk is a huge thing that they don't know about. And that is it. Thank you very much for your talk. I hope you work together with the board to really help improve what they're doing. Thank you.
All right, next we have Anne Fukua. If you are on the phone, go ahead and dial in *3.
Hello? Can you hear me?
Yes, we can hear you.
Okay, great. I just want to make sure. My name is Ann Fuquay. First, I would like to thank Dr. Thorpe and his fellow board members for granting the request of advocates like Kristen Ogden and I and placing the topic chronic and intractable pain on the agenda for today's meeting and inviting Dr. Mackey to speak. We pro-patient policies that ensure patients have access to whatever types of treatment work best for them. Opioids are but one treatment, though they are the most heavily restricted. They aren't without risk and don't help everyone. I've been truly blessed. These meds are like a miracle drug for me, though. They have literally given me back my life. I've been on a stable, albeit high dose for over a decade without need for increase, signs of endocrinopathy, or sleep apnea. I'm an opioid therapy success story, yet I cannot find treatment in my home state. I searched throughout the U.S. until Dr. Tennant agreed to treat me. I'm now under the care of another California physician who has continued to work far past retirement age. I'm incredibly grateful for him, yet I know I will be searching for another physician much sooner than I would like. I've been to numerous academic medical centers and seen some of the most respected physicians in the field. Even they have expressed the medical legal risk associated with a patient like me is just too great for them and their institution. All I want to do is keep the quality of life I have now. Sadly, this seems like too much to ask. I'm so grateful that I managed to find a doctor willing to treat me for now, though. I thank God each day. California's Intractable Pain Act freed patients like me from the hell of pain, but now most physicians fear they will face sanctions even if they follow the Act's regulations meticulously. I hope that you will follow Dr. Mackey's advice regarding the importance of California taking a leadership role nationally with regard to opioid prescribing. As you work to revise the California Controlled Substance Guidelines, I hope you will purpose to ensure that physicians can be pro-patient, even when the person is a high-dose patient like me. I'm a person too. I just want to live the best life I can. On a final note, I would love to participate as a stakeholder in your work to revise California's Controlled Substance Prescribing Guidelines. Thank you.
And then we have Rosie Arthurs-Doder next. Hello, are you there?
Ms. Arthur's daughter, if you're speaking, we can't hear you. It appears from my attendee screen that you are off mute, but we can't hear you. Angel, are you able to try to troubleshoot her?
Currently looking into it.
Okay, we'll give it just a minute.
Can you hear me now? Hello?
Yes, much better.
Can you hear me now? Hello?
Yes.
Yes, we can hear you.
Okay, thank you. This connection today has been extremely poor. Okay. I'd like to make several comments on Dr. Mackey's presentation. When he talks about needing high quality data, we've gone over this in previous meetings, how with these electronic health records and other records, that oftentimes falsified records are being generated both to incentivize more pay for various third-party payers, be it workers' comp or Social Security or Medi-Cal. So that has created an industry where everybody is looking to make money and the patient has been forgotten. In the and with the exclusion, I will say the academic pain management consortiums are not a part of this problem, but in the private practice, large practice pain management providers, oftentimes they are run by workers' comp defense attorneys who incentivize their providers to provide substandard care. And there are examples of double and triple billing for procedures or testing that wasn't done, etc. And nobody follows the law. That pyramid with the red top, one would think that that would be the people who've been disciplined. In fact, they probably belong in the next level down, because when you look at what they did in those cases and you look at the laws, you find out those with intractable pain, they're skipping over that and not acknowledging that. The ones that are in that top red circle, or top of the pyramid, are pretty much the large pain management doctors who are following the CDC guidelines that were meant for naive patients. And even when the CDC took it back, they still keep going at it. It's abominable what you find. I can't go into it. The problem with intractable pain, I've been following it with the board
30 seconds.
for 10 years almost. You need to put the regulations on your site. You need to put the law so the doctors can see what the law is. That's why they're afraid, because you take it down and you have refused to put it up there so that people can see it. And my son is dead because of the policies designed by this board.
Please conclude.
Okay, so you have to remember, these policies don't save lives. They hurt people and they take lives away of useful, vibrant, wonderful people. And every time one of these patients is injured, their whole family is injured as well. Thank you.
At this time, I do not see any more comments or raised hands.
Ms. Lawson, you're on mute.
I'm sorry, double muted. Thank you, Carrie. Thank you, Angel. Thank you to all the public commenters. I'm going to go ahead and bring it back to the board. Are there any final comments or questions? Mr. Pasifka?
Just very, very briefly. First of all, I want to thank Dr. Mackey for giving us a very good presentation and for being so generous with his time and with his expertise. And just to very briefly follow up on one thing that he said in terms of us reviewing the guidelines on controlled substances, I just want to reiterate what he said. Our goal is not simply to replicate the work of the CDC, but through working with Dr. Mackey and many of our other very excellent experts, we have learned that California has many unique problems. That what we want to do is to come up with guidelines that will add value, will address the very unique problems that we face, and particularly address the problems of fear and of access. And with the assistance of Dr. Mackey, we look forward to doing that and coming up with something that is very much tailor-made for the California problems that we face.
Thank you, Mr. Pasifka. Are there any final comments or questions? All right, seeing none, thank you again, Dr. Mackey, for the extraordinary presentation. We appreciate it. I know the members of the public appreciate it. And like Mr. Pasifka said, we certainly appreciate the generosity of your time this afternoon. Thank you.
Madam Chair, this is Dr. Thorpe.
Yes, Dr. Thorpe.
Sorry, I don't want to delay things, but would it be possible to get Dr. Mackey's PowerPoint
Yes.
to the board members?
I
That would
can,
be, that'd be
I'm
great.
just replying, Richard, I can follow up with the PowerPoint, and then, you know, my partner who I mentioned, Dr. Darnell, who's on the line also, she was texting me saying, we can get them all the information they want for resources and we'll forward it along. And as always, she's usually 3 steps ahead of me. So we'll forward you the, you know, that information and the other things that were requested, and anything else you want, you just let us know.
Terrific, thank you. All right, I'm going to move us along to our next agenda item, which, because we took agenda item 4 already, we are moving on to agenda item 5, which is the President's report. And I just have a few brief things to share with all of you. First of all, I wanted to thank everyone again, especially the members of the public, for joining our first quarterly meeting of the year. I wanted to wish everybody a happy new year, and it's my sincere hope that this year is one of good health and good cheer for all of you. Since we last met in November, Dr. Hawkins and I have had the privilege to work closely with our board staff on the legislative proposals that we discussed and approved at our November meeting. With leadership from Aaron Bone, a detailed memorandum was prepared and circulated to the legislature, and the month of January was very busy with meetings with legislators and legislative staff to discuss our proposals. Those meetings have continued this month, and we will hear more from Mr. Bone tomorrow about the status of certain aspects of our proposal. I would like to extend a special thank you to board member Alejandra Campoverde. Unfortunately, she couldn't be with us this afternoon, but she has been very active in our conversations with key legislators, and she lends a very important perspective to the discussions about the need for the reforms that we have proposed. I am extremely proud of our proactive approach, and I have been encouraged by our conversations with legislators. I do believe that we have an opportunity to make a difference this legislative cycle, and I look forward to continuing to work with all of you and with our staff to enact the changes that will help us fulfill our mission to protect consumers and promote access to quality medical care. Of course, consumer and patient protection is our paramount responsibility, and I believe that this responsibility includes the duty to protect the public from misinformation and disinformation by physicians and other healthcare professionals. As the Federation of State Medical Boards noted in a July 2021 statement, there has been a dramatic increase in the dissemination of healthcare-related misinformation and disinformation on social media platforms, online, and in the media. This disinformation puts lives at risk. In some cases, it leads to patient death, and it causes unnecessary strain on our healthcare system. Disinformation also erodes public trust in the medical profession and the healthcare system, and is a breach of the individualized trust that is the foundation of the physician-patient relationship. FSMB's statement in July of 2021 accurately advised that physicians who generate and spread misinformation or disinformation risk disciplinary action by state medical boards. In partnership with the DOJ and HQIU, our staff are working to address disinformation-related complaints as we receive them. Cases involving misinformation and disinformation can present unique disciplinary challenges, and we greatly appreciate the input we have received from FSMB, members of the public, and members of the legislature about how we can work together to ensure the standard of care is followed and patient harm is prevented. Confronting this problem from our perspective and jurisdiction will require new thinking and approaches, and it might require legislative updates. But make no mistake, it is imperative that we confront misinformation and disinformation and take action to discipline licensees who traffic in misinformation and disinformation. I hope to have additional updates for you on this important issue at our next meeting. And lastly, I do want to thank the many members of the public who over many years have offered productive, critical feedback and input to all of us. We do want to improve, and we welcome your suggestions about how to do just that. Unfortunately, there are members of the public that choose to approach their interactions with our board members and staff with incivility and terrorizing tactics. No public official should be subjected to harassment, threats, or intimidation for doing their job. I would like to thank our staff and members of law enforcement, including the California Highway Patrol, who work behind the scenes to keep us all safe and ensure that we can continue to do good work. With that, I invite any comments or questions from you, and then we'll go to the public. Are there any comments or questions from board members? Angel, if you could please open the line for the public.
Christina. That's Randy.
Sorry, was that Dr. Thorpe? Oh, sorry, Dr. Hawkins.
Have you heard anything more about the unfortunate incidents that occurred regarding you personally being approached? Do we need to speak to that, or?
I don't plan to say anything more about that today, except to say that it continues.
Now, Christina, this is Dick Thorpe. I just wanted to say thank you to you and Dr. Hawkins and Ms. Lubiano for your excellent work, and we just appreciate all you do. I appreciate all you do.
Thank you very much. Yeah. Thank you very much. All right, Angel, if you could open it up for public comment, please.
Absolutely. First up, we have Susan Lauren. There we go.
Hello again. Thank you. And I couldn't agree more about the misinformation and disinformation, it being a problem. And this has been going on for decades, as you know, with plastic surgeons and dermatologists and others who are doing scam procedures on people. And I am asking you to reprimand them and to stop them, because so much harm can be prevented, and we need new thinking and legislative updates around these topics. And the Medical Board of California began before these kinds of procedures were even I can't think of the right word, were even in use. And I did provide some, I hope, comprehensive information to the Medical Board on my suggestions to update Title 16 subsection of the CCR subsection 1356.6, which is a liposuction code. I really want to see action on this. We need to act on this now. I really don't want anyone to think, oh, well, that person went for liposuction and roll their eyes. Most of us, like me, go in for another procedure they need, and if someone does go for liposuction, they go because it's minimized and lied about all over. So what are we going to do? Seriously, what are we going to do about this misinformation and disinformation that's causing this bloodbath and all these people being in intractable pain, disfigured, disabled? What are we going to do? I mean, really, it's more than time, and I'm doing everything that I can to help you. And I'm looking for answers. I'm not sure why Terry Dubrow, for example, is your expert, and I'm waiting for an answer on that. How is he your expert? And he's going on TV and giving disinformation about these procedures, and he's doing it with the blessing of the Medical Board. Oh, he's our expert. He uses that a lot. He uses it in court. He uses it on TV, and the Military Health Agency banned him, and he lied in my trial, as you know, 1,000,000 times. But why would I stop talking about it when it's still a problem? So I'm sorry my voice goes up. It's, partly the intractable pain, and I look forward to this. I look forward to action on this year. And please help me protect the public. Please help me protect the public. Thank you.
Thank you for your comment. Next, we have Rosie Arthur's daughter again.
Can you hear me now?
Yes.
Oh, good. All right. I've been saying it for more than 8 years, and I'll say it again. I don't understand why the Medical Board removed references to the Intractable Pain Act from its site and from its guidelines when they are the law in this state. And along with that, removing references to the business and professional codes and regulations, etc.
Ms. Arthur's daughter, could I ask you to stay on the topic of the president's report that I just provided?
Well, you were talking about communications, people communicating and bringing issues to you. And I've been bringing these issues for 8 years, and they land on deaf ears. And it seems like if you're a lawyer, I don't understand why you don't see the necessity to restore the notice to the public of these laws to your site. Why can't you print what the CDC said about pain when its policy was being misused? These are things that the public needs to know. If you're guarding our safety, why are you hiding these things, especially when there are laws and regulations? It just seems that that's a part of handling communications. It shouldn't take 8 years to put something back in that never should have been taken out. Why are you hiding access to the laws? Then maybe somebody needs to review all the disciplinary cases. Because if they're not following the law when they're reviewing it, we have an organizational problem there. Anyway, that's how I see it. You have laws and regulations that are meant to protect the public, and those are not being utilized, and it causes people to think it's been changed when it hasn't. And it encourages bad medicine and any number of other frauds, like billing frauds, etc. Thank you.
Ms. Lawson, I just wanted to let you know that there is still a link to the medical board's laws, the Medical Practice Act, and other provisions of law that the board uses. It's still on the board's website.
Thank you, Ms. Webb. All right, Angel, let's move on to the next public commenter, please.
Thank you. Next, we have Dr. Ree. Go ahead, Dr. Ree.
Yes, thank you. So Hannah Ree here with Black Patients Matter. Thank you for the update, Ms. Lawson. It's very, very informative. And as you know, I've been coming to these meetings for quite a while now, having sat through at least 2 or 3 other board presidents. I do have to say though that I think you are the first to complain about patient comments or public comments, referring to them as terrorist threats and thanking the CHP. I don't know what I don't know what you go through as a board member, but as far as the public, we are just advocating and we have anger and it's emotional. So we're offended that you would thank the police for doing what? What? Writing the laws, defending the laws? Why are you bringing in the California Highway Patrol? That is inappropriate. Ms. Lawson, in all honesty, you are coming across as a Karen. You are coming across as white privilege and haughty. So I wish there was a better way to tell you quietly, but there isn't. Maybe if someone reviews this later, you will see the difference between how you're coming across and the other presidents. So that's all. Thank you.
Thank you for your comments. Next, we have Eric Andrus. Go ahead, Eric.
Can you hear me?
Yes.
So I have a public record request in, which Carrie will likely deny, to try and find out how often you all meet with the CMA when discussing legislative proposals, etc. I want to figure out how often they have a say, but then you never meet with patient safety advocates to get our point of view. So you can spout consumer protection as your priority, but when you meet with the CMA and you purposely stopped meeting with us, it proves otherwise. You talk about FSMB, but remember, they were part of the scandal over their participation in the document titled Responsible Opioid Prescribing. So why should we trust statements they make, Christina? The FSMB isn't any more trustworthy than the medical board. Christina, you need to stop talking about being terrorized when you didn't even file a police report in your incident. You have become quite a drama queen in your details in that matter. I don't doubt something happened, but I think you're simply exaggerating things to deflect all the bad press you and the medical board are now getting. You're extremely judgmental, and your harassment now of consumers, and I assume mostly me, is out of line. It's not your job to harass consumers and voice your judgments publicly on this medical board meeting. Shame on you. Just shame on you, Christina Lawson. We put you in that position. Don't you dare talk to consumers the way you just talked. And talk about disinformation. How about you all bragging about your terrible app, which doesn't work most of the time? It's not an easy way for consumers to get information on their doctors. You all sit there and pat yourselves on the back for all your good works, but never bring up the bad things that you do and how you don't talk about things like the lawsuit against the board by one of your own employees who was sexually harassed by a supervisor, and Kimberly Kirkmeyer let it happen. You don't talk about those things. That's omission of information is disinformation as well. You're not telling the public about all the bad things that happen at the medical board. That's disinformation. You all are just as bad about it, so you have no room to complain or reprimand anyone for disinformation. So stop it, Christina Lawson.
Okay, thank you so much for your comment. Next, we have Virginia.
I'm kind of lost for words right now. Deep breath, everybody. So I agree with Miss Lauren on disinformation. We need to have accurate information, not only about vaccines and COVID, but also like procedures like liposuction. Also, the medications we're handed. Doctors are trained by the pharmaceutical companies about the medications, and they have an alternative motive. So we had disinformation about how safe or unsafe these medications are, and that is disinformation. And when we complain about the side effects and they're blown off, that is a huge concern. And also, well, I appreciate that you were able to get safe care after your event. None of us can. There's no place for us to turn. And it felt really uncomfortable seeing you be able to get help and on all these news medias with your issue, and yet all of us are sitting there not able to get help, and no news media will take our information. And that makes us feel very, I can't think of the word, but it's really concerning. It breaks my heart that there's nobody to help me. No news wants to hear about my story. Nobody wants to help. So it'd be nice if we all got the help when it happens and not 5 years later, because people are getting hurt from doctors that hurt people 5 years ago, and they're still being hurt because it still hasn't been against the board. So, and I'm still really glad that you got safe and you are safe and there was support for you. I wish we just had the same support. And I'm sorry that you had to go through everything that's been said previously. That's it.
Angel, are there any further public comments?
Oh, yes. Apologies about that. I was muted. Yes, next we have Marianne Hollingsworth.
Hello, can you hear me? Hello, can you hear me?
Yes.
Okay.
Go ahead.
Hello, my name is Marianne Hollingsworth, Patient Safety Advocate. Regarding Ms. Lawson's update on COVID misinformation complaints, I was wondering whether the board is pushing these cases through faster since it is more time sensitive, By your own admission, the board cases usually take 3 years from start to finish. So because of this, I was wondering if these misinformation complaints are being reviewed faster than the usual doctor complaints, if you're able to answer that, because if we wait 3 years, it could make these complaints moot. So is there an answer that's available at this time? That's basically just my comment, to ask a question about how those are being handled.
Angel, are there any additional public comments?
At this time, I do not see any additional comments. Oh, sorry, looks like one more just came up. Coda J. Go ahead.
Hi, thank you. My name is Jules Coda. And again, I have to say it's been so informative to be able to sit and listen to this board meeting over the last couple days. And I really, really want to thank the board for that opportunity. You know, my heart is broken just like the other people who have shared their stories and their frustrations. And believe me, that's how I sound at any given time, talking about what my family is going through and our particular reason for contacting the board and everything. And what I did want to say on that is, first of all, Miss Lawson, I applaud your grace that you're handling all of this with. I don't know if I could have sat through the way some of these people spoke to you today. And for the public, I apologize for that because I'm angry too. And I could never speak to somebody like that who's trying to help us. So thank you for your grace in this because you're dealing with us at the end of our rope. And I know that I can get crazy emotional and stuff. So I sympathize with my, fellow public. And I also invite them to have an opportunity to take a look deeper, because what I did was looked deeper at what the board is doing about all of these complaints. And I found a lot of information. I found that they're trying to create a liaison program to help filter these complaints so that you have someone with you each step of the way. I found that they're introducing new legislation and that they want patients and victims more involved in decision making and disciplinary actions with the doctors. So I have to say that it was humbling for me because I came in guns blazing like many of us do. And I am relieved to learn that there is action being taken. Now, granted, am I upset? It's a long time coming and it might take forever. Yeah, of course. We're all impatient and we want it now. But I really applaud the board for taking these steps in the face of a lot of these egregious accusations and stuff that do end up in the papers and things like that. So I applaud you guys and thank you for that. And then back to like my actual questions is I know a lot of this centers around accountability. So what I want to talk about, or what I want more information on, is the cures reporting system and exactly how it works. What is the step-by-step of who reports, what's reported, what is it paying? Like, it's a Department of Justice program, I'm not sure. Is it an automatic flag when certain things are written or entered? I think clarification on that and better cross-checking, thank you, would be really informative, not only for doctors, but also for patients, because there's accountability there showing what the doctors are prescribing, what the patients are receiving, and from where and which doctors. I also think an effort should be made to make that database national so that they talk to each other in other states. Thank you again for your time. I've really learned so much from getting to listen. So I really, really appreciate this. Thank you.
Thank you for your comment. At this time, I do not see any other raised hands or comments.
Thank you, Angel. We'll bring it back to the board. Are there any comments before we move on to agenda item 6? Mr. Rue?
Thank you, Ms. Lawson. I just wanted to, for the record, also say thank you so very much for all of your hard work, your grace, compassion, demeanor. This is very difficult and polarizing times, yet you have persevered. Any leadership position, and in particular, this leadership position of our board, is one of the most difficult. And I know you've personally faced difficult issues, and I know you've gone above and beyond your role and the amount of time you spent on the board, pushing for all patients in California. And I know there's 12 of us, and I just know that personally how much you've reached out to me amongst your busy schedule, just as as the president's duties, has been amazing. And I could just imagine you have to do that 11 times over. So I really appreciate all of your effort. I just wanted to express that one more time during these difficult times. And I want to just thank you for your perseverance.
Thank you. I appreciate that. All right, let's move on to agenda item 6, which is board member communications with interested parties. Before I go to the other board members, I just wanted to share that Ms. Campaverde asked me to share with all of you that she has written letters to both Senator Hurtado and Assemblymember Lee, and then she's had a meeting with Senator Hurtado to discuss our legislative proposals. As I mentioned during my president's report, I've had meetings with a number of stakeholders. I regularly receive inquiries from the public, all of which I forward to our staff to the extent that they need additional follow-up. And so do any other members have items to report? And please unmute your computers if you wish to speak.
Randy, just briefly.
Dr. Hawkins.
So I recently participated in a Food and Drug Administration webinar from the FDA Center for Tobacco Products. The topic was rulemaking process and planned tobacco product standards to prohibit menthol as a characterizing flavor in cigarettes and flavors in cigars. This is early in the process. Folks who are interested could reach out to fda.gov, Center for Tobacco Products.
Ms. Lawson, Dr. Kennedy. So as I mentioned, I do regularly communicate with my local legislators, and on this one, I did communicate with my 2 local assembly people on AB 1400, which was single payer system, which never came to vote. But I do, as I mentioned, I do not get involved with the medical board issues, but there are a lot of healthcare issues I do communicate with the local legislature.
Ms. Lawson and Dr. Thorpe, I just wanted to mention that on January 12th, I met with the California chapter of the American College of Physicians to discuss the need for expert reviewers and to encourage them to reach out to their membership to encourage training, to encourage them to participate in training to become expert reviewers for the medical board.
Lawson, Dr. Mahmood.
Dr. Mahmood?
Yes, as I have already communicated with you that I have launched a campaign to run for Congress. And during that process, I have met many assembly and state senators and many congressional members with just with my congressional campaign for their endorsement. And I just wanted to make sure everybody knows that I'm running for Congress in District 40. But that is my political work, entirely separate from medical board.
Thank you, Dr. Mahmood. Any other reports on board communications with interested parties? All right, we will open this up for public comment as well. Angel, if you could open it up.
Okay, let's see. All right, we have one from Coda J.
Just for clarification, this is just for public comments on any of the board member communications with interested parties.
Hi, Jules Coda again. And correct me if this doesn't apply. Would something like this apply to like deconflicting between other organizations? Like if there's a police department involved, or if there's like an FBI or DEA or something like that? And if this doesn't apply here, that's totally fine. Just cut me off, no problem.
Ms. Webb, would you just mind giving just a short couple sentence overview of what this agenda item is for the public
Sure.
benefit?
Yeah, the point of this agenda item is to alert the public if board members have had communications on items that may be coming before the board for a decision. An example would be, we have legislation that will be discussed tomorrow, and if they have met with lobbyists relating to that legislation, that would be important to disclose. So that's an example of
Okay, I understand. I understand much better now. Thank you so much. I don't think my concern applies to this area. Thank you. I apologize for taking the time.
Thank you. Angel, are there additional public comments?
Yes. Next, we have Dr. Ree. Go ahead, Dr. Ree.
Yes, thank you. Hannah Ree for Black Patients Matter. You know, I've still got that feeling of feeling marginalized. So I wish, Miss Lawson would, point to some people to speak directly to us, seeing as how, some other folks got to be spoken to. But in any event, so I want to commend Dr. Mahmood for running for Congress. I would just say that I would vote for the candidate that understands the times that we are living in, that understands the importance of vocabulary such as diversity and inclusion and tolerance and that sort of thing. So congratulations again, Dr. Mahmoudi. Good luck to you.
Thank you for your comment, Doctor. Next, we have Reminder Gill. Go ahead.
This is Reminder Gill. I'm a physician at UC Davis Medical Center. I'm a member of the American College of Physicians. I wanted to thank Dr. Thorpe for his time in speaking to our group, and we did pass along to membership, encouraging any and all interested physicians to become reviewers. I just wanted to acknowledge Dr. Thorpe and the other members of the medical board of California for doing what often is a thankless job, but we recognize while there are many physicians doing wonderful things each day, indeed, there are some that are not, but I thank you for your service.
Thank you for your
Thank you. Are there additional public comments?
At this time, I see no comments.
All right, I will bring this back to the board. Are there any further comments before we move on to the next agenda item? Seeing none, we will move on to the next item, which is item 7, updates from external stakeholders. And I believe we have Ms. Castro, Ms. Nichols, and Ms. Holmes with us, with Ms. Castro up first.
Good afternoon. I hope that you can hear me. A very brief update in the interest of time. The Attorney General's Office of the State of California has published our fiscal year 2020 to 2021 data pursuant to Business and Professions Code Section 312.2 on accusations prosecuted on behalf of all Department of Consumer Affairs client agencies, of which the Medical Board I have the privilege of representing. It's available on our website. Our website is oag.ca.gov under Resources, Publications, and Civil Law Division. And this would be our 5th annual report, publishing different metrics, how many cases were adjudicated as required by Business and Professions Code Section 312.2. And that concludes my remarks. I did want to thank the Chief of Enforcement, Jenna Jones, for including pertinent information on administrative outcomes for the cases managed by your investigators and your lawyers at the Health Quality Enforcement Section and Health Quality Investigation Unit, as well as publishing data on stipulations specifically. So with that, that terminates my presentation. Thank you very much.
Ms. Castro, thank you. We're going to move on to the next update from Ms. Nichols before we take board member comments. Thank you.
Good afternoon. I'm Deputy Chief Kathleen Nichols. It's my pleasure to update the board on the Division of Investigation's Health Quality Investigation Unit. There are currently 13 investigator vacancies, which is a 16% vacancy rate. There are 15 candidates in background, and we continue to conduct hiring panels to identify additional candidates so we can immediately fill these vacancies. At the last meeting, I shared that 2 of our commanders retired at the end of the year. I am pleased to announce the promotion of Joe Vaughn to the Southern Area Commander position. Joe began his career in law enforcement in 1993 with the San Bernardino County Sheriff's Department and retired in 2018 at the rank of sergeant. During his career with the San Bernardino County Sheriff's Department, Joe worked custody, patrol, investigations, SWAT, and narcotics. He was a patrol watch commander and supervised a detective division and traffic division. Joe started his career with HQIU in 2018 and recently held the Supervising Investigator 1 position in our San Bernardino field office. Thomas Morris has been appointed to handle commander duties for the LA metro area. Thomas's sworn peace officer career began in 2001 as a federal officer with the United States Park Police. Thomas transitioned to state service in 2006 as an investigator with the Department of Alcoholic Beverage Control. He started his career with DCA in 2007, where he was assigned as a medical board investigator and was promoted to the test and supervising investigator position in 2014. Thomas is also a veteran of the United States Marine Corps. We have continued to make progress on our aged cases and have analyzed what is causing delays to implement process improvements to reduce our timelines. One of the most frustrating time delays in our investigations is our ability to timely receive certified medical records. Part of the process is to ensure that the record certification matches with the number of pages that we receive. Most often, these certifications are not correct, and investigators spend countless hours trying to rectify certifications with facilities and doctors' offices to obtain correct certifications, which are required for a case to be accepted by the Attorney General's Office for Prosecution. This back and forth causes delays and interrupts the progress of the investigation. We have just added a 5th analyst position to our Expert Procurement Unit, EPU, utilizing our existing positions, which has posted, and we will be conducting interviews soon. When that position is hired, we will transition the responsibility for obtaining correct medical record certifications to EPU. This will create more efficiency in the process and allow investigators to spend time investigating and not handling administrative records issues. And now I'd like to share our updated graphs. I don't know, Angel, if you have those or if you'd like me to share.
Sorry, 1 second.
Okay. As you can see from the updated graphs, we continue to reduce our pending workload and are reducing the number of cases over 1 year old. In January 2020, the pending workload was 2,340 investigations. At the end of December 2021, our pending workload was 1,529 investigations, which is a net reduction of 811 investigations. The second slide, if you could move to the second slide, Angel, illustrates the number of cases in HQIU over a year old, which also continues to decrease. From January to December of this year in 2021, we have made a net reduction of 284 investigations over a year old. As we continue to be successful completing the aged cases, the closed case average number will rise, but it's a reflection of the older cases being completed. All investigators received training in December with the Attorney General's Office regarding subpoenas, subject interviews, and expert review. There was a statewide medical consultant meeting in January, which included training on good cause for subpoenas. We are currently scheduling sexual misconduct training for all investigators, which will take place in the spring. Investigators also received training in December on time tracking, as we are now tracking all investigative hours for cost recovery, which took effect January 1 of 2022. A special thanks to the DCA Breeze team and Medical Board's ISB and data teams for their quick rollout of the time tracking feature so we could implement this so quickly. We continue to hold weekly meetings with board staff to discuss aged and priority cases, in addition to sending our automated monthly report with our case status updates to board staff. I look forward to my continued meetings with the board staff, and this concludes my update.
Thank you, Ms. Nichols. I think we're going to hear from Ms. Holmes next.
Good afternoon, Board President Lawson and board members. I am Carrie Holmes, Deputy Director of Board and Bureau Relations at the Department of Consumer Affairs. Thank you for allowing me to provide a department update. DCA appreciates all board members and staff who have continued to serve through a pandemic that has affected all of us in many ways. California and DCA have continued with health and safety mandates to protect employees, consumers, and our communities from the spread of COVID-19. State employees must show proof of vaccination or be subject to regular COVID-19 testing when working or meeting on site. DCA's testing program has expanded to additional sites, home testing for qualified employees and voluntary testing for fully vaccinated employees. As California moves into an endemic reality, a new state public health order will lift universal masking for vaccinated individuals beginning February 16th. Unvaccinated individuals must still wear face coverings in all indoor settings. In some high-risk settings, such as healthcare facilities, face coverings will be required for everyone, regardless of vaccination status. Local orders may be more restrictive to respond to community conditions. Please remember that as state representatives, we are all expected to adhere to all state and local orders while carrying out our duties. On January 5th, Governor Newsom signed an executive order that allows boards to meet remotely without listing board member locations through March 31st, 2022. DCA and its boards and bureaus have recognized the benefits of remote meeting options, including greater public participation, reduced costs from travel, and a reduced carbon footprint. I'm happy to let you know that on January 31st, AB 1733 was introduced to permanently allow state bodies to meet remotely while also requiring both virtual and physical options for members of the public to participate. If this bill is passed by the legislature and signed by the governor, it would take place immediately. We cannot be certain that AB 1733 will be enacted or when, so boards need to prepare for the possibility of an in-person meeting after March 31st. Before attending any in-person meeting, members must verify full vaccination with DCA's Office of Human Resources or participate in COVID-19 testing. If any members have not yet done so, please submit your proof of vaccination. Your participation will assist DCA in planning for testing at future meetings. I want to express my appreciation for the flexibility of board members, staff, and the public as we have navigated this pandemic together. I'm optimistic about the future, and I look forward to meeting you in person one day. As DCA looks to the future, Director Kirkmeyer continues to lead the department towards continual improvement and excellent service. DCA is pleased to announce that Tanya Corcoran has been selected to serve as the department's first Compliance and Equity Officer, effective March 2nd, 2022. Ms. Corcoran brings invaluable expertise, insight, and years of hands-on experience with DCA boards and bureaus to this new position. As a special advisor, the Compliance and Equity Officer will provide leadership and policy direction related to quality improvement measures and to help improve DCA's organizational equity culture. This position will also oversee DCA's Solid Training and Planning Solutions, Organizational Improvement Office, Equal Employment Opportunity Office, and Internal Audit Office. Bringing these offices together under Ms. Corcoran's leadership will be a tremendous benefit, allowing DCA to better identify and analyze emerging issues department-wide and provide timely solutions to DCA's boards and bureaus. Another initiative, DCA's Enlighten Licensing Project, was created in 2020 to utilize licensing subject matter experts within the department. The group is intended to help individual boards and bureaus streamline their licensing processes by utilizing practices, information technology, and cost-saving measures. The first deep dive, which was into the Board of Registered Nursing, recently completed. A report will be released in the near future with recommendations that can be used by all boards and bureaus to improve their licensing processes. After the successful first round, the work group will move on to another board or bureau. I'd like to provide an update on the department's efforts to establish the Enforcement Monitor created by Senate Bill 806. The Enforcement Monitor will provide a thorough, timely, relevant, accurate, and unbiased review of the medical board's enforcement program and provide recommendations where appropriate. The monitor will be brought on through a contract with the Department of Consumer Affairs. A request for proposals, or RFP, was posted from December 29th, 2021 until January 18th, 2022. Unfortunately, due to a lack of proposals, DCA has gone out for a second solicitation. This RFP was posted on January 21 with a due date of February 22nd at 1 p.m. DCA is actively seeking a contractor for this project. Information regarding this solicitation has been shared across DCA's social media as well as DCA's website. The solicitation has also been shared with national associations and organizations, as well as consulting firms who possess the experience required for the review. If any attendees of the meeting meet the qualifications or know of an entity who would be a great fit for the position, the RFP is published online at caliprocure.ca.gov. To ensure independence, remember the Enforcement Monitor may not have any affiliation or financial relationship with either patient or physician interests. As a final reminder, board members have training and reporting requirements. Each year, board members are required by law to file a Form 700 disclosure before April 1st or face penalties from the FPPC. DCA requests that board members file as soon as possible. If anyone needs assistance, DCA's filing officer and legal counsel are available to help. Board members who are recently appointed or reappointed need to attend board member orientation training within a year of that appointment date. You can register for the BMOT through the Learning Management System, or LMS, which is DCA's training portal. Live virtual trainings will be held on March 9th, June 15th, and October 12th. This is a required training for newly appointed members, but we also encourage it for any member who would like a refresher. Board and Bureau Relations is happy to assist with any questions about the BMOT or the LMS. As always, Board and Bureau Relations is here to help. If there's anything we can do to assist, please reach out. This concludes my presentation, and I'll hand it back to Board President Lawson.
Ms. Holmes, thank you for your remarks, and thank you again to Ms. Castro and Ms. Nichols. Are there any questions or comments from board members of either Ms. Castro, Ms. Nichols, or Ms. Holmes? Dr. Gananadev?
Yeah, Ms. Lawson, thank you. This is for Ms. Nichols. Ms. Nichols, I really thrilled to see the timeline going down and the numbers going down. I thought they might happen after the cost recovery was in effect, but good to see that it's happening even before. Can you give me a reason? Is it staffing, or what is making it go down, even though I'm glad to see it?
Well, I think we're finally getting our staffing up, although we still have vacancies that we're trying to fill. At one time, we had a 40% vacancy rate and just a large influx of cases. So it has taken us quite some time to work those cases down and get our aging numbers down. But it's our commitment to keep doing that. And one of the things that we look at is looking at the process itself and where are our delays happening, and then attacking those delays and trying to find creative solutions so that we can speed up the timelines. And I think the record certification is a good example of that. And I'm very excited to see the improvements that can make as we go forward in that project.
Are the plaintiff's attorneys, or not plaintiff, I guess, respondents' attorneys are aware that there is a cost recovery? The longer they drag things on, the more it will cost. They might have to pay back.
I'm hopeful that they are going to be aware of that. And because all the delay tactics and the things that take our investigators time when we're not gaining cooperation from subjects or their attorneys, that is going to add investigative hours to the case. And ultimately, at the end of the case, that's going to add money to the cost recovery.
Okay, thank you.
President Lawson, I have a question.
Mr. Watkins, please.
my first question is to Ms. Nichols.
Mr. Watkins, can I just pause you for a minute? I'm just having trouble hearing you.
Oh,
you're coming in a little bit faint. If you could just come up to your microphone.
Okay. My first question is to Ms. Nichols. I would like to kind of understand the qualitative process that goes in investigations, because I'm looking at the back end and the back end numbers are not good. But I want to just ask, my question is, what's the most common failure that you see that affects your investigations in cases that translates downstream?
The two biggest things that cause delays in our investigation is our ability to timely get all the certified medical records and the ability to interview all the witnesses. And sometimes we don't get cooperation with either of those two things. So as the cases move on, part of the process is we have to obtain those records, and sometimes they're from multiple providers. We've had a lot of situations recently where even when we get authorizations from patients, when we serve them on the subject physician to get the records, the next thing that happens is the investigator gets a call from the doctor's office to say the patient has rescinded their release and they no longer want to cooperate with us. And that's happening more and more, unfortunately, and there's nothing in the law that prevents it. So then that makes us have to then subpoena that patient's chart. It's a longer process. So that's definitely something that's been a trend recently. Another thing is just at the end, when we're ready to interview that subject physician, getting that physician in for the interview before the case can go to an expert. That sometimes is a very lengthy process. Physicians have their attorneys, which is their right, but it's everybody's schedule that's involved. It's the investigator schedule, our medical consultant schedule, the subject and their attorney, and all four schedules have to match up. And so sometimes that back and forth causes delays, but even more so when they're not being cooperative to set the interviews in a timely manner.
Thank you. My next question is to Ms. Castro. I've got a few. I just, is Gloria on? Yes, it's Ms. Castro. So usually every year I do a summary of everything, just like a little check sheet for myself. And last year, this time, I pointed out my issues with the not following the disciplinary guidelines. You pushed back. So I think over the last year, we've established that the board in general feels that, deviating from the guidelines and specifically the probation period, which is commonly in the board space, the primary deterrent element that is used, and we don't follow that like 80% of the time. Those numbers are consistent. My question is, I want to create some cooperation. How do we fix that? Is that fixable? That we could follow the guidelines like, I see 80% of the time we deviate. I understand some of the time that we deviate, but 80% is just too much of a number. When I've looked at other boards and their number is 80% enforcing that primary guideline. And I know the guidelines are not binding. I know all of it, but they are there to promote uniformity, certainty, fairness, and mostly deterrence in the furtherance of public protection. Right now, what I'm seeing, and very clearly there's a trend here because I've got 2 years numbers right now, is that when we write all these PRs, I see that we get the information from your department and we get a lot. Last year, we got a lot of PRs. And in those PRs, 40% of those PRs was related to, expert issues. The expert didn't cooperate. That didn't. The previous year, it was like 36%. So we're in the range. And even yesterday, the numbers of expert issues out of the total number of STIPs we did was around 45%. So those numbers trend like that. I just want to, my view is to fix it, to come up with a solution. But I feel like most of your folks, from what I'm hearing, which was incredibly informative to hear the candor to hear that it's being candid, have the answers. They know which laws to fix. They know, you all know all these exit points that prevent us from being in a stronger negotiating position, and also then they give us the ability to actually enforce those disciplinary guidelines. So my question is, do you have any guidelines for that we could do as a board that can help us move closer to getting those statistics? Because those statistics point to how we measure, how we do implement these laws. And right now, what I've been saying all along, that tends to happen and benefit the doctors mostly. If we don't if we deviate from the guidelines, it benefits them, and there's no deterrent effect. And the public, the patients, advocates that come and present their pain to the board, they feel and they see this. And I just want to address that. That's my sincere hope to move forward. So I just want to hear from you. And I want to thank you for yesterday, for your staff being really candid. I appreciate that.
Is there a question you're asking me? Because
Yes.
I can make suggestions to you on how you could be more effective. First of all, the data that you reference is a mystery to me. So I would encourage you to provide it to Ms. Lawson and Ms. Webb, so we could start to tackle the issues that you see as a member of Panel A who only sees half of the stipulations we send to the board on an annual basis. Secondly, I think there's a lot to unpack in your comments and how you feel. But all I can tell you is that fairness and balance that we discuss in those closed sessions where we are attorney-client protected and work product privileged, fairness and balance is the goal, and it does not equal bias. So I'll begin with that. The medical board is our client. We're not pro-doctor, pro-patient. We are trying to achieve fairness with our recommendations that we run through your chief of enforcement and very senior people in our office and myself. The medical board is not the only Department of Consumer Affairs client that has guidelines. And I was happy to hear you say that they're not binding. And I would encourage you to watch Ms. Webb's presentation, actually all of the board members and even the public, from May of 2021, where she took pains to explain the disciplinary guidelines. So I don't want to replace what she said way more eloquently and much more prepared than I could to what I still don't know is a question. Secondly, may I finish?
Sure.
In August of 2020, we also presented to you the standard of care presentation and the prosecutorial burdens. And I come in here quite a bit and tell you to look at the statistics. And today I mentioned your own enforcement chief's statistics. She will discuss those, and you can ask her questions about anything you want on agenda item 9B. She has shown you how many stipulations are presented, how many are held, and how many are rejected. Our data that we publish for the Attorney General's office also reflects on multiple levels how many hearings, stipulations, and defaults we get, and then as a percentage, how many revocations and surrenders are achieved, in addition to the public reprimands and in addition to the stipulations. And so I think together, all of those things will help you to answer some of those questions for yourself, but it's all there. It's not easy work. The disciplinary guidelines are an initial benchmark, and it allows board members, judges, trial judges, opposing counsel, and ALJs, as well as doctors, to see what the initial benchmark is for violations, not for what's filed, but for things that we can prove as a board. And this is all based on facts. It should assist you to not be arbitrary or discriminatory. It should assist you in exercising your discretion and ultimately on a case-by-case basis. So together, the presentation I gave and vetted through our office on standard of care, Ms. Webb's presentation on disciplinary guidelines, which is the Bible on what disciplinary guidelines are for this board. Like I mentioned, all boards have them at DCA, thankfully, to be able to order behavior. So at the end of the day, it is not arbitrary or capricious, which is what we always have to fight on writs once those things are appealed to a higher authority. And finally, medicine is not a field of absolutes. I don't think any doctor on this board would disagree with that. And there's always a need for doctors to execute their professional judgment as to what course of conduct was necessary and most appropriate in regard to the patient's specific condition. So I encourage you to share those stats. Once you do that, then maybe I can help to answer some of the questions that you have. And I want to thank you for your comments so that we can improve. And it is truly a privilege to be able to represent this board and to do this very difficult work and to have those discussions that are ultimately very important, very hard, and we do very well. We have surrenders, we have revocations, and when doctors choose not to exercise their due process rights by defaulting and not filing a notice of defense, we revoke them. And so we do a really good job on that. And that's been consistent across the board.
So just in response to what you're saying, you know, it has a kind of condescending tone, but I'll let that go. First of all, if you think I don't have a knowledge of this, then you're sadly mistaken about my level of understanding of this and the level of work that I put behind this. The presentation that Carrie made back then, the standard of care, those are what you would like things to be if it was a perfect world. The reality is that that's not the way it is. That's not the way the board operates in any way, shape, or form. You know that there's going to be on any given day, there'll be expert issues, right? There'll be expert issues that will come up and we'll write a letter of public reprimand or we'll give the doctor discount, which is 40%. That's standard. When you can see trends like that, you don't need my data. You can go through your own, we can go through all the data. The trends doesn't lie, and it doesn't lie in 2 years. And I'll gladly give everybody this documentation. And then here's my request. Then I would like you to use these numbers and bring out the same numbers of when we quote public reprimands and the primary issue that was given for issuing such a public reprimand. Give us the answer to that and put it out for all the 300 and something, say 60, 83, steps that we did last year. The numbers at the bottom line, the outcomes are not beneficial. It does not serve the public. And I will stand with that. And all this other, now I just understand that this is the way it's going to be. I'm going to have a position and the board is going to have a different position. The only difference, the only problem with that is we have actively people calling in pain and people that rather would dismiss the medical board and saying, well, they protect the doctors, right? But we don't care because we don't care about them. We don't listen to them and they don't have a legal right, as we will argue tomorrow. But I don't want to belabor the point. This was more like to find a common ground, which we can't, because you have your position and I have bottom line facts, and I've been doing this my entire life. So I'm very confident in where this is going to go. So I just want to thank you because it just clarifies things for me and where I stand and where the public stands, simply. Thank you.
One topic that you raised was on public reprimands. Your own disciplinary guidelines allows it for single patients. Where appropriate, it may be ordered. And secondly, in addition to statutes, guidelines, uniform standards, things like that, we're also guided by sources and legal authority that are actually used in the medical malpractice context. Things like jury instructions and the finding of negligence and breach of due care and duty owed. Luckily, in our cases, we don't have to reach everything else. We just care about whether a duty was owed and whether it was breached. And again, medicine is not a field of absolutes. And that is well established in the Barton versus Owen case from 1977. So thank you.
All right, thank you, Ms. Castro. Are there other questions of any of our presenters? Mr. Rue?
A quick question from Ms. Nichols. The two charts that you provided, there's a bar graph and a line graph. The line graph I know is for cases over a year. Is the bar graph also cases for over a year?
No, the bar graph is showing our pending workload. So how many investigations we currently have.
So it's total, right?
Total cases. Mm-hmm.
So basically, if I'm reading it correctly, I'm looking at the older version, not your updated one that you presented. For December of 2021, there was 1,529 pending cases. And from that, a little less than half, 701 are cases over a year. Is that
That's
right?
correct. That's correct.
Thank you. Great job. Great job in reduction.
Additional comments before I open it up for public comment? All right, Angel, if you could please open the line for public comment.
All right, thank you so much. First we have up is Coda J. Go ahead.
Hi, again, my name is Jules Coda. Thank you for this opportunity. So informative to be a part of this. I'm so grateful. I have to agree with a lot of the points that Mr. Watkins made, and also commend what you guys have been doing to reduce that caseload and work through cases in a timely manner. Again, I can't help but point out the element of triage being involved, specifically when there's like blatant crimes involved. Is there a reason that these types of things can't be immediately offloaded to law enforcement? Things where there's like, sexual abuse, children, or death. Is there a reason some of these can't be or aren't offloaded right away to law enforcement for criminal prosecution? And then also speaking to that about the burden of proof, I believe you guys are working on changing kind of what the burden of proof is so that it's more in line with what other states say as well. But also, again, drawing from my own personal experience, like as the victim's family, I have all of the proof. I have like the burden of proof can be on me. We have everything. And a lot of the times the patients do and the families do. And if it needs to be verified in like a legal manner, which again, I'm not an attorney, I don't understand about that process, but I know there was talk of like subpoenas and requesting information from doctors. Again, if cases that are blatantly criminal could get turned over to law enforcement, could that be a way to reduce the workload and put these cases in the proper hands of the proper people so that the board can focus on what the board should be doing and what you guys are doing in protecting the public, instead of trying to find the manpower just to make it through the influx of complaints? Again, I'm not an attorney. I have experience with boards and things like this and processing, and that would just be my opinion, especially as my own family is trying to deal with, our issues that we brought to the board, which are largely criminal and should be moved over to a criminal case, like no problem. And the board should be relieved of having to deal with some of these things. And in some of these criminal cases, there shouldn't be a question about medical licensing any longer. It would appear, especially like we said, if you're involving sexual abuse, children, and death. And yeah, so that's all I have to say. Thank you again, TJ Watkins, for speaking up so much. Thank you, Ms. Lawson, for being so receptive. And I definitely have a new opinion and outlook on what this board does. And I really thank you guys for listening and enacting some of these changes. And I'm excited to see that there is new legislation being written and new investigative groups being formed to help mitigate these problems. So thank you for that. I appreciate it.
Thank you for your comment. Next, we have Rosie Arthur-Stoder.
Hello. This question is for Ms. Castro. I brought it up earlier in regards to the board's removal of notice to certain laws and statutes and regulations revolving around the Intractable Pain Act and then the business and professional codes, etc., that allow these patients to be treated. And what I have noticed on the disciplinary cases where intractable pain is the issue is that I don't know if it's the reviewer who's confused or the person in the AG's office. They stop at A and they don't go down to C, which is the part of the regulation or statute that covers it. So you end up having a number of people who should have been protected by that law, both the patient and the doctor, finding themselves out of business and along with all of their patients and their patients' families. So it has a devastating effect when somebody should have been protected, both the patient and the doctor, under the law, and they get prosecuted or disciplined because somebody stops at A and doesn't go to C, which is the pertinent part. So I think there should be a review of that. This also has crossover effects in cases where involving workers' comp, where they say workers' comp is the exclusive remedy, and that's not always so. And in those cases were dropped where there really was great negligence on the part of the doctor, and it was thrown out because they said, oh, workers' comp is the exclusive remedy and workers' comp allows that type of care. And then they said, anyway, we don't have authority over these doctors. And then, of course, the workers, one of the workers' comp doctors was disciplined and lost his license, and another one of the ones involved didn't. Now, that just may be that something's still in the works.
30 seconds.
So you have conflicting things, and I think somebody needs to be reviewing this, you know, in light of the fact that the board has left off references to these very important items from their website that used to be there. You know, and if I was prosecuted for something like that, I would be very upset when I was following the law. Okay? Thank you.
Thank you for your comment. Next, we have Dr. Ree.
Yes, thank you, Dr. Ree from Black Patients Matter. So as some of you may or may not know, I'm the only person here in this meeting who has gone through the whole process, and I know of it from the inside out. Having said that, I'm just going to say what we all want to say, and that is, Ms. Castro, you are lying. And that's why at least two, maybe I get confused with all the lawsuits, but that's why 2 or 3 of your attorneys are defendants in a federal civil rights lawsuit that's ongoing since 2018. Okay, so whoever it is at the office who's pulling the strings, you are able to adjust your cases so that you retaliate against individuals such as myself from filing lawsuits. Okay, I was revoked after I filed the federal civil rights lawsuit. Okay, so and as an aside, I'm wondering if I'm thinking that it's probably not in the best interest of anyone to group these three speakers together, Ms. Castro, Ms. Carroll, excuse me, Ms. Nichols, and the third, because they're so controversial and there's so much feedback to say that to group them together and then only have a couple of minutes to be able to comment is not just. So I would ask that maybe we not do that again. So in any event, Miss Nichols, you are lying. I know other people want to say it. I'm just going to say it. You are lying. Well, not lying as much as adjusting the truth or exaggerating. So it seems that your office is able to, however, take time, longer time on certain cases in order to make them fit into a criteria. When you are pursuing someone you really want to go after and you're not able to find the expert witness you want, as in my case, and so you have to search high and low, and that takes time. In my
30
case,
seconds.
you got, why are you shortening my speech versus the other one? It could be because I'm Black Patients Matter. In any event, cases are delayed, not, and you're lying, Ms. Nichols. Cases are not delayed. It's not the physician's fault that you're going after. The fault is that your office is trying to pursue cases in retaliation for physicians. That's
Please conclude.
why you have all these people calling about serious cases. You're not going after serious cases. You're going after cases to retaliate against.
Thank you for your comment. Next, we have Eric Andrist. Go ahead.
Wow, Gloria Castro, so passive aggressive. Don't start snapping at TJ Watkins when he's becoming quite a hero to the people of California for calling attention to the problems and illegal activities of this board that the AG's office is clearly overlooking. Sounds like you're just afraid his actions are going to reveal just how incompetent and complicit the AG's office is in all this mess. Public reprimands should never be used for first-time doctors whose actions ended in a death, and you all bartered the charges down to bookkeeping so you could give them a public reprimand. So stop the straw man arguments, Gloria. We're on to you. Talk about a conflict of interest. It's ridiculous that the DCA is in charge of finding an enforcement monitor now that it's being run by the very person that helped run this board into the ground in recent years, Kimberly Kirkmeyer. Then again, DCA executive directors don't last long. Maybe they're just trying to get rid of her. And speaking of Kimberly, did you see DCA's recent tweet about recognizing Black History Month? I guess they've forgotten under Kirkmeyer that the board was found to be targeting Black doctors more than other races. Guess they're trying to backtrack now and make it look like they're racially sensitive. And for those that don't like the things that I say or the way I say them, remember, it's this board that created me by not doing right by any complaint I've filed, including in the death of my sister. You reap what you sow. And to Jules Coda, I've been monitoring this board for 5 years full time. You have no idea what you're talking about. And in your argument against anyone's criticism of this board created what I am. Christina Lawson is playing receptive, likely on her quest for a political career. Until she became president, she sat on her hands, nary saying much of anything during her whole time as a board member, until I would call her out on it. The evidence is in the videos of the past meetings. Everyone should go back and watch how Christina didn't participate as a board member. It was pathetic. Thank you.
Thank you for your comment. Next, we have Susan Lauren.
Hello, can you hear me?
Yes.
Hi. I know we're all tired. I know I am. And I want to thank TJ and the other activists. I'm going to be sure to do that. So saying that medicine is not an art is often an excuse. Medicine does not include scams, assaults, and cover-ups. And my case of egregious surgical battery was one for criminal prosecution, and nothing was done with the board. And the evidence is there. My body is the proof. And I had a lot more evidence. And to not deal with this, I'm asking for a full public apology, or you can't move on honestly. I need a full public apology. It won't do anything for my life because my life is already gone. But you need to acknowledge something in order to deal with it honestly, and you just haven't. And it's not an apology to say, well, I'm sorry that you feel that the board didn't do blah, blah, blah. It's not a feeling, it's a fact. And someone mentioned 3 things that would be the worst things are sexual abuse, children, and death. Well, I don't think we should leave out surgical assault and those of us living in living hell. And I asked earlier today, but surgical assault should be on your consumer page next to sexual misconduct. And I baffled as to why it's not. And yeah, I mean, the serious cases makes no sense why. I really am clueless as to what kind of, cover-ups and everything could go on, or what kind of absolute just disregard for my life and for all the other people's lives that are being harmed by these scams, assaults, and cover-ups. Anyway, it's late, and yeah, to the woman that thinks everything looks peachy, I wish that I had that outlook, but in having been mutilated alive and I'm going to die young from this, and having this board treat me like it did, Kimberly Kirchmeier said, it's my belief that I don't have a part of my body. No, surgeon removed it. So I really wish that I was back in a reality where I had that kind of, teary outlook. We have to change. We have to change. And yeah, thank you for your time, everyone. And thank you again, TJ.
Thank you for your comment. Next, we have Virginia. Go ahead. Virginia?
The little tag just showed up. So if we're not talking, it's because we don't have the unmute thing. So the medicine is not absolute comment. When you let, again, somebody bleed to death for 5-10 hours, and then they still have a license, that's what we're talking about. When you Picasso young women's bodies with surgical assault, that's what we're talking about. Of course, there's some things in medicine, it doesn't work out and bad things happen, but most of us calling, it was preventable and you guys did nothing. So hearing medicine is not absolute, it's just frustrating. And the condescending tone aimed at TJ was very frustrating. And patients not willing to participate after they started it, maybe because I was threatened for $1 billion if I didn't remove my Yelp review. And the doctor said, oh, I don't know you, even though she did surgery on me and threatened me. So we get these threats all the time from these doctors, and that's why we don't participate. And you want on these medical records, yet they're all falsified because you won't deal with the falsification of medical records. She put all these work and let's get these records for what? Because only a person with a crystal ball knows whether they're true or not. So if you don't deal with false records, there's no point in getting the records. Because then you don't have enough evidence, and then you're like, oh, we close the case because we don't have enough evidence. You don't have enough evidence because you asked for CDs for information that's like 1990, and we're in 2022. and the board wants a CD. Who has a CD player nowadays besides the board? I don't know. So how can we get the right information, the correct medical records, so we have enough evidence so you can do the absolute right job? How is that possible? We've been asking for this for how many years now? It has not been on the agenda. Again, I went to the doctor today and I'm like ashamed of my medical records because they're all false. I'm like a horrible person and my medical records isn't true. I have to defend my medical records on top of having PTSD, on top of being in pain. And then my medical records are false and I can't get them fixed. And you guys won't help me. I want help. I want correct medical records. And I don't know what to say by reading you guys' body languages because I don't know what that means.
15 seconds.
So at what point in time will I get correct medical records? Will you fight for me at the legislative point and do away with the CMA and actually do your job? At what point? And dear Coda, if you lived this like we did, you would understand.
Thank you for your comments. Next, we have Tracy. Tracy, if you could go ahead and accept the unmute button. Go ahead.
Thank you. I just would like to thank TJ Watkins really for asking the hard questions that families need answers to. I appreciate it and heartfelt because we carry the deaths and we carry the hurt and the medical negligence every day. And I appreciate you asking those questions that families need answers to. And I just want to say that. Thank you.
Thank you for your comments. At this time, I no longer see any additional comments.
Thank you, Angel. We will bring it back to the board. Are there any additional comments or questions before we move on to the next item? All right, seeing none, we'll move on to the next item, which is item number 8, updates from external boards. And for this item, we have Ms. Melby and Dr. Hawkins. Is Ms. Melby with us?
Yes, I'm with you. So this is,
Welcome.
I'm Loretta Melby. I'm the executive officer for the California Board of Registered Nursing, and I was updating you all on the implementation of AB 890, the pathway to independent practice for nurse practitioners. We had our NPAC meeting on Tuesday. They voted on not having a naming convention for the nurse practitioner that's described under the .103 section. That is the nurse practitioner that is independent within a healthcare facility or a group setting. That independence just means that they're operating without a standardized procedure. They did not believe that a naming convention was appropriate at that point and that they would continue with just the identification of a nurse practitioner as well as the person that has just graduated their training in their education academics and became a nurse practitioner. So those levels would stay nurse practitioner. The suggestion that they have going to our board, which our board meeting is scheduled for next week, is that the .104 NP be called an independent nurse practitioner. Those are the nurse practitioners that can work independent within a private practice underneath their national certification. That was voted on. They're continuing to work with discussing the use of our disciplinary guidelines. I saw that that was a very robust commentary here on our board, your board. So they are looking at the disciplinary guidelines for nurse practitioners. Our nurse midwife advisory committee will be doing the same review, looking at the disciplinary guidelines and providing input. So we will be updating our disciplinary guidelines, which will go through the regulation process into the Office of Administrative Law for approval. So we look forward to that happening over the next year. We are also doing a desk audit to establish a fee for the additional category, which is the 104 NP. That is the one that we were given the statutory authority to go after by the passing of AB 890. I'm here for any additional questions that you might have. And thank you for allowing me to come in and give these report outs to you guys.
Thank you, Ms. Melby. And we're going to move on to an update from the Physician Assistant Board, Dr. Hawkins.
Good afternoon again. The Physician Assistant Board last met virtual this past Monday. I refer you to the PA Board homepage, but the website is being updated. The address is pab.ca.gov. To access the agenda, materials, and approved minutes, click on the tab on the right side of the homepage entitled Quick Hits. Next, click Board Meetings, and all the agenda and materials are available. Finally, I encourage the PA Board staff and board members to view our meeting and highlighted some agenda items for today and tomorrow. That ends my report.
Thank you, Dr. Hawkins. Any members of the board have any comments or questions for either Ms. Melby or for Dr. Hawkins? All right, hearing none. Angel, if you could please open up the public comment line again and call for public comments.
Okay, I'm going to go ahead and open up to Rosie Arthur-Stoder. Go ahead.
Thank you. Okay, my comment is on the nurse practitioners. I have a concern there, particularly for the ones working in pain management, because they are put in and some they're furnished nurse practitioners. So I don't know if these would be nurse practitioners across the board, or is it just specific to the general nurse practitioner? Because what I have seen in these large practices where the doctors farm a lot of their work out to nurse practitioners, sometimes the quality just isn't there. They're not being supervised. In one small practice, in one small office, about 4 different nurse practitioners treated this patient, said they reviewed records when they didn't, et cetera, et cetera. And when you get the records, you was like, oh my gosh, what's happened? But the other thing I found is when I looked, it was hard because they gave a different name. They'd say the name was Susan when it was Donna, etc. And that when I would look up their records, I would find out that as they got out of school, they were disciplined by the board for substance abuse, or one was for elder abuse, etc. And that was never disclosed when they were treating patients, improperly. And if that's the oversight that the board currently has now, I'm wondering how making them independent is going to improve that situation. It's very distressing when it's not just one that maybe made a one-time error, but 2. And why are practices such a difficult group of patients relying on people who have had substance abuse problems or elder abuse problems? It seems like those people need more time before they're allowed to practice on their own. That's just my observations from just a small number I've seen. That's 50% in one particular office that had extreme problems. Thank you.
Thank you for your comments. Next, we have Dr. Reed. Go ahead, doctor.
Yes, thank you. My apologies. That was done in mistake. We don't have any comments. Thank you.
All right, thank you for that. Next, we have Coda J.
Thanks, Jules Coda. Again, thank you for allowing me to participate. This has been so informative. And again, I do have a question directed towards the nursing board, particularly about background checks on people who apply to become nurse practitioners. And what does that process look like? I know another public attendant was discouraged with my hopeful attitude towards the future, and I promise I'm not. You know, this is a professional public meeting, so I try to keep a decorum about me. But I'm heartbroken like everybody else. My sister was killed by my father, who is a doctor, and his friend, who is a disgraced judge who was disbarred and then somehow got to become a nurse practitioner. And they both overprescribed my sister to the point of death. Then they kidnapped her daughter, my niece, and have abducted her and taken her out of state, and we don't know where she is. And so I am dealing with a lot of distress, and I am dealing with frustration about, you know, the board and what are they doing about it and what have they done and what could have they done different to prevent it. So what I'm doing is trying to really understand the process of how this happens and what led to these things so that I can be knowledgeable. And as well as while I'm working with other agencies like law enforcement, I can bring them the appropriate concerns that I have. So talking about nurse practitioners and the nursing board, that is one of my questions, because my personal situation does involve some pretty egregious crimes, including murder. And I want to know what is done about background checks, because this person, specifically in my scenario, who was prescribing to my sister that killed her, it was my dad and a friend of his who have had previous criminal history together. So these men already had a criminal history and were still able to become, you know, disbarred as a judge and then go and become a nurse practitioner. So I am trying to find out where that breakdown happens, where, like, you know, I mentioned before, I hold a cosmetology license, which in no way compares. However, I had to appear in front of my board to explain to them why I got drunk in public when I was 20 years old. Even though here we are 20 years later, I don't even drink alcohol, but I still had to appear and make a case to my board about something that was a mistake in college.
30 seconds.
And thank you so much. And so to see that other people who are doctors holding people's lives in their hands aren't being even held to that standard that even I was held to as a hairdresser. So I'm grateful to have you on this call. I'm sorry, I didn't see what your name was, who was speaking about the nursing board. So those are some questions that I would have. And thank you for giving me the opportunity to share that.
Thank you for your comments. At this time, I no longer see any more comments.
Thank you, Angel. We'll bring it back to the board. Are there any further questions or comments from members? All right, seeing none, let's move on to our next agenda item, which is agenda item 9, executive management reports. I will turn it over to you, Mr. Pasifka.
Thank you very much, Madam President. We have 3 rather lengthy reports.
Mr. Pasifka, we're having a hard time hearing you.
Okay, is that better?
Much better, thank you.
Okay, I'm sorry for that. Madam President, we have 3 rather lengthy reports. I will take them all as read, but obviously there are a number of important things that I want to point out to the board. First, beginning with the administrative report. It's been a very busy time for the board since the last board meeting. And in particular, this was driven by 2 events. One was the implementation of SB 806, which caused a great deal of changes to our processes. And so we've had to be very proactive in terms of meeting with stakeholders to make the transition, particularly in the licensing area, as seamless as possible. And secondly, as you yourself have indicated, we have a very ambitious legislative agenda, and that has also entailed a great deal of public outreach. And we continue then with the normal stakeholder meetings, particularly working very closely with the Attorney General's office and HQIU. And I can assure all members of the board that interactions with those bodies really take place on a daily basis. and a substantive basis at a very high level, sometimes on a daily or certainly weekly basis. So it's been a very important period of interaction. Moving to staffing updates, we welcome 4 new employees during the last period, and we continue to fill the vacancies as frequently as possible. Moving on to the budget update, this board is very well acquainted with the fiscal position of the board. They know that we are approaching the point where we are basically rapidly reaching the statutory reserve limits. I can report to you that since the last board meeting, our projections for the end of the year have improved marginally. We are now projected to have reserves at 1.9 months, but as everyone knows, going forward, we will need additional funds beyond that which will be provided by our existing revenue. I think everyone realizes that, and this year we will be moving forward to look for further increases in the registration fees to cover what will be our inevitable deficit moving forward. In terms of the coronavirus update, the medical board has been subject to recent outbreaks, just as has the rest of the state. And as we indicated, in the middle of January, 8 employees missed 1 or more days of work during that 1 week alone. So we've been all affected by it, but we all look forward to what we hope will be the eventual recovery. In terms of external communications, we do note that this has also been a very busy time. We brought out another edition of our newsletter. There's been a lot of work in terms of outreach, preparing for the implementation of SB 806. We have a special web page. We've hosted live webinars in order to brief licensees and stakeholders about changes. And as we also indicated to you, we've issued an 11-page memo to members of the state legislature, the governor's administration, and the media, setting out which I think can only be characterized as a rather ambitious legislative proposal so that we can work more effectively and more efficiently, and also in some regards to bring California in line with the powers and the burden of proof, for example, of other state medical boards. We have been working on the complaint tracking system. We've been working very closely with the DCA, and we are looking forward to making a more comprehensive presentation on the project at the next board meeting. We had a physician survey design, which was due to be effective in July of 2022. Some of these additions had to be put on hold pending other legislative changes. We look forward to completing those as rapidly as we can. We've made significant progress on the print yourself wallet and license cards going forward. And finally, as indicated at the end of the report, WebEx training events for the medical experts program is a very important part of what we do. As will be indicated later, the medical experts are really the heart of our enforcement efforts. They're very critical, and we place a huge priority in terms of the training there. For people who have been fortunate enough to have attended the training, they know that it's quite comprehensive and it's very relevant, and it remains an important priority of us to work with and to improve our medical experts. Moving on to the enforcement report. One thing that I wanted to brief you on, to give you some ideas of the challenges and the complexities that the medical board faces. In early December 2021, the Purdue Pharma case, which was brought against the medical board, in which there was a subpoena put on us for very exhaustive list of medical records, that was finally concluded. The litigation hold regarding Purdue Pharma was lifted. And to give you some idea of the capacity constraints that were put upon us is I actually looked at to defend that case, which was not our case. It was a case that was brought against us. It took 3,500 hours of the Attorney General's office. As a result of the litigation, we had to put a hold on our normal process of purging documents. As a result of that, when the eventual litigation hold was lifted, we had 700 boxes of documents, literally thousands of files, which then had to be reviewed, which had to be memorialized before we could purge them. It was a project of just ending that litigation hold, which took 60 members of our staff working on and off during a 2-week period. And again, this is work that takes us away from our core functions. So it's a matter of time, and of course, of resources. And so this gives you some idea of sometimes the challenges that we face. And I certainly want to thank the staff for their dedication and their agility and flexibility to manage to shift from, if you will, their day job to this one-time enormous project. As indicated, we work very closely with HQIU, and we work closely with them in terms of reducing timelines, of eliminating old cases, and trying to bring cases to a timely conclusion as rapidly as possible. As we have indicated in the enforcement report, a request was put for a list of the stipulations that were put forward to the various panels and for their outturns for the last 5 years. That is all included there. Issues have been raised about how we manage complaints, and particularly how we close complaints. So in this enforcement report, we have a rather comprehensive description of what causes us to close significant portions of complaints. And as you can see there, from the initial complaints that are brought in, there is a significant portion, upwards of close to half of complaints, which fall into what we call unactionable complaints. These are complaints that fall outside of our jurisdiction, are redundant complaints, are complaints where there is simply not enough evidence given to us at a very preliminary point in order to go forward. After that point, cases can continue into investigation, but we try to give a further breakdown of other types of cases and how they are closed for insufficient evidence, evidence that there is no violation. And then, of course, we have other complaints that are ultimately closed because we cannot meet the clear and convincing standard of care. So I think it's important from our point of view that the board understands that, again, there's a significant portion of these cases we close very early simply because we don't have the power to action them. But everything that can go forward, I have to say, does go forward. Going on to the expert reviewer program, again, we have 611 active experts. To manage that level of experts is almost itself a full-time job for any board. We are continuously in the process of looking for additional experts, reviewing the work of experts, training experts, and this work will never end. And actually, we're forming a new internal task force to meet on this with the particular point of looking to fill positions for additional experts. Moving on to the central complaint unit, as indicated further in the document, the average number of days to initiate a complaint is down to 5 days. There's been a significant improvement there during the past 6 months. In addition, we understand the board is very concerned about our interactions with complainants. And so we have been very proactive in this in doing this. What we have done at the earliest stages of interaction, we have identified a number of different milestones in the complaint process. These are milestones that are largely driven by the movement of complaint from within the investigative unit to a medical consultant, to an investigator, to the Attorney General's office. And we are committed to informing the complainant directly at each point that milestone has been made. The managers and the staff have been working very hard here. We've worked very hard on training the staff, and we have also been monitoring the staff, monitoring the outcome there. And as we indicated, we are doing this in a sort of systematic way, and has been indicated in the past 6 months, we've seen some improvement. And now, which is all set out there, we haven't hit, if you will, 0 problems, but I think we have made a lot of improvement, and the board can be assured that we've taken their direction very seriously here. Our monitoring staff, training staff, where there are cases where milestones have been reached and the complainant was not notified, we identify this, we reach out to staff, we educate staff, train them, and we're looking to continuously improve. And we have other projects that we're looking at in order to improve our communications with members of the public, with complainants, and we hope to bring that further to you at the next board meeting. Moving on to the licensing area. Licensing staff have been extremely busy during this time, particularly in the changes to licensing as a result of SB 806. They have to be congratulated for that. But at the same time, they've kept the review time for the PTL and physician surgeon's license within the statutory timelines, as has been set out there. The Mexico pilot program, what we said at the date that the report went out, we had issued 6 licenses to physicians. There have been 4 more issued since that time, so the number is up to 10. But the medical board and the delayed applications, which I guess amount to 14 ones, the reason they have not yet been issued is because they haven't gotten their visas yet. But we are prepared to issue those as quickly as possible. There's an additional waiver for COVID that has been extended there, but obviously we're looking for those waivers all to come to an end. Consumer Information Unit was extremely busy, receiving over 16,000 inquiries. And again, we've set out there our outreach in relation to SB 806, and myself and the staff would be happy to answer any questions that you would have.
Thank you, Mr. Persifka. Are there questions from board members? Dr. Gananadev.
Yeah, Bill, I'm just looking at the budget. I know that your expense reduction, I can see a little bit there. But if you borrow $18 million, how are you going to pay it back?
Well, what we have done is, as you will understand, we will be appearing before the legislature this year. In SB 806, it was set out that we would be holding, that there would be a review of our fees. And so we have been doing a lot of work on that. Obviously, a loan of that size with a 2-year repayment, at the very least, presents cash flow challenges, needless to say. But what we have done, and we've been working ourselves with our team and with DCA budget, projecting that if we get the full amount, that we will approach and we will meet financial sustainability. Now, it will be challenging in terms of a cash flow perspective to both borrow and to repay that. So we're trying to do everything we possibly can to deal with that problem. But the bottom line is that if we get the fee increase that we are looking for, we will be able to hit financial sustainability, certainly in the medium term. Maybe would Mr. Varghese like to comment on that?
Actually, Bill captured most of it, but this actually underlines the fact that the small fee increase that we received is not enough for a sustainable future. So this really underlines and highlights it very much. So we, like Bill said, we are working very closely with DCA budget and looking at different options, and we'll be reapproaching the legislators end of this year or maybe earlier than that to see if we can get some help in that regard.
Okay, so my concern is I think we all agreed that we do need a fee increase, even though it's one of the highest fees in the nation compared to any other state. But if especially on the AG's office side, if the expenses keep going up, we got a real problem. So that's why I want to make sure that we are financially sustainable, because I don't expect State General Fund to pay anything for our expenses. And when your license fee already is one of the highest in the nation, then I'm not sure how we can manage. That's why I'm sure you're aware of it and you're seriously looking at, and that $18 million borrowing just scared the hell out of me. Let me put it that way.
Additional questions, Mr. Watkins?
Hi, Mr. Pacifica. Well, you can rest easy. It's not going to be controversial. Thank you for putting out that data. I appreciate that. I think I've been remiss to acknowledge you and Reggie in the way, you miss a point, but your financial management of this board under these circumstances have been, as a previous CFO, pretty impressive. And your strategy of taking out the 18 million credit line that is there, that's pretty robust. And I really see the thinking behind that financially. I have a question, with the enforcement. I'm always having questions about enforcement, but it's an easy question. In the no violations finding, that 2000 or whatever number, 2,702 number, is I just want to understand, when we find no violation, it goes to a consultant, which is a medical expert. We have notorious expert issues. It constantly gets dismissed by the DAG that are experts. I just want to know, on this end of it, do we have I hate to use the word better experts.
Sorry, would you say that again, please?
I said, I want to know on the no violation file.
Right.
We use medical consultant and experts. And, on the other side of the tail end with the egregious cases, our track record is not as impressive with the experts. There's always issues with the expert. I want to know, just for my own peace of mind, how reliable are these experts in making that summary of the case that we find no violation? And how do we verify that it is in fact no violation? Is there a multi-point check on that? What does that entail? Because I think why I'm asking that is because many of the people that we call in, it's because no violation is found in most of those cases. And that would really help everybody in understanding what happens. So thank you.
Okay.
And actually, Mr. Watkins, if I might just add on to that question, because I had a question about the same chart, and I had a question actually about what that no violation category meant. Does it mean that there's no violation of the Medical Practice Act? Does it mean that, for example, maybe there was an insurance or a billing complaint. I guess I didn't understand what that category meant. And so I would just like to add that on because I think it's related.
Okay, I will ask Ms. Jenna Jones to deal with that question.
Good afternoon, and if I may address your question, thank you for allowing me to speak. So I assume that you're talking about the pie chart that's on page 9B4, and that talks about the no violation. Now, no violation is a case that has gone before a medical consultant, and the medical consultant has reviewed the records that we have obtained and the complaint and determined that there's no violation or not enough information to move forward. We do have a chief medical consultant, and his role is also to monitor those cases and evaluate them. So we do have kind of a check and balance to get, in many cases, a preliminary review and then a secondary review. So I feel very confident with our process in that. But I'm certainly open to any recommendations you wish for us to consider. Ms. Lawson, your question was what goes into those. The billing generally are non-jurisdictional, so they would have fallen into that other category. The
Great,
anonymous complaints, again, but it's when we've actually had enough information available and we've taken it to a medical consultant. Thank you.
Just a quick question, Ms. Jones. I use a scorecard on all my measurements in my own different practices in my business. And I was wondering if you have an indication, like the cases that that the medical consultant sends through, that goes right through the system, right? How many times, just a rough estimate, how many times do that opinion that was there holds to the end, right? To the end of the process. So if they found out extreme departures and, or so I'm talking about the other part of it, where it goes through a medical consultant, it passes through the medical consultant, now it goes to the AG and all of that, the second part of the process. Do we know, how often do we get it right in that part of the process? When we say there is a violation and if we've made the right determination, and right now it's going to be upheld at the end. I know that's a difficult question, and that probably is a little bit more than just to know offhand, but I'm just curious.
You are absolutely right. I don't have a number to give you today. I will be happy to research that though and do a sampling and see and get you a percentage for the future board meeting or in the time in between. I feel like we get it right a lot of times, but I don't want to misspeak, and I don't want to. If you allow me the time to research it, I'll be happy to get you a number.
Absolutely.
But
thank you.
Also, if I could intervene here, as I try to indicate in my own summary, the executive considers the management of the experts to be one of their most important functions. And in fact, it is an area where we all acknowledge that we need to improve. One of the frustrations that we feel is, very frankly, we are frequently outbid for experts by the people on the other side. Well, so be it. But we need to manage our experts as effectively as possible. We put a big emphasis on training, on monitoring them, on reviewing them, on, if you will, deciding that there are some experts that we are not going to use anymore, and also, very importantly, to reaching out to more experts. It has always been my particular view that we will never have the resources, if you will, to outbid the other side. However, what we need to do is to impress upon our stakeholders that the work of the medical board is extremely important, and that a practitioner who is at the very top of the profession will find it in their interest professionally to perform that function for the board, that it will be a matter of prestige, of eminence, and this is the one thing that we can give that others cannot. So we need to reach out, to renew our reaching out to the training bodies, to the centers of excellence, that the people at the very top of the profession should consider devoting a part of their time to the work of the medical board, that this will be of great service to the profession and to the public.
Speak, Dr. Mahmood.
Dr. Mahmood, please.
Yeah, so continuing on the same topic of medical experts, ever since I have been on the board, this has been constant discussion that repeatedly we are failed because our medical experts cannot prove the case or they perform very poorly. And every single meeting, I heard the same thing. We're doing this, and this, and I haven't seen any improvement. What kind of reprimand we have done on those people? When people, we see most of the cases we lose, we fail because our medical expert performed a very poor job. I understand that other party can pay more. If we get competitive people, even not paying that much, I think we can get it. Attorney General's office wins so many cases out in the court when other side has much higher paid attorneys, and this doesn't happen in medical board. And I think if we go back on last year or 2 years and see these people have repeatedly failed us, just get them out. I mean, put all this effort, bring them on and still fail, lose all those resources and still fail. Why do you use them? And we need to really come up and say, okay, this is what we have done and this is showing the result. Not like every 3 months we say, okay, we're going to do this training, we're going to do this better hiring, this and that. Result is zero. So I think we really need to put this number one priority. If we need to satisfy the public, and if we need to satisfy the board, and if we need to provide the quality service, that medical experts should be performing their job. Because I think, I have the feeling, they just don't even read the case. They just come on the day of presentation and they have so many lapses. A normal practicing doctor can do better job than those medical experts who are supposed to be specialized in that field. So we really need to act on this like yesterday. We should not just make a plan. We should have showing in the action and getting the results.
Well, I can assure you, we do discontinue the use of medical experts. We need to renew that commitment to discontinue the use of certain medical experts, but that will put even greater burden on getting new experts. And we must do all of that. And I agree with you that it must be an absolute priority of the board.
Do you have any number? How many
questions? Yeah. I'm sorry.
Do we have, sorry, I'm sorry. Do we have the number? How many people we fired or we let them go because their performance was poor? Or can somebody provide us, like last 1 year, how many people you let them go, not they went? So that will be a good step to start.
Okay, we will attempt to come up with that information.
Thank you.
I saw multiple hands. Mr. Watkins, had you concluded your questions that you had?
Yes, thank you. Thank you to the.
Thank you.
Wow.
I'm sorry, did you have something further?
No, just thank you to the staff for doing all this.
Thank you. Ms. Lubiano?
You're muted.
Can you hear me now?
Yes.
Yes.
Oh, okay. Sorry about that. So my two questions, I don't think they're very difficult, but just for clarification. So on that pie chart we were talking about on item 9B, page 4. So back to that no violation part of the pie, the purple part. So just to clarify, is it correct that that could include cases where there's just one simple departure, and you know, even though there's one simple departure that could have included some great harm to the patient. Is that right?
No, ma'am. Ms. Lubiano, that the no violation means there was no departure. The insufficient evidence, the part below that, the blue part, that would be if there was one simple departure.
Okay, great. Thank you for that. And then my second question, also for the public's benefit, because I know there was a question. So it says 25 files were referred for criminal action. Can you explain again where generally in the process it would be referred if there was criminal action or suspicion of criminal action?
Sure. So that line is that's usually after an investigation, and either that investigation is done by HQIU or by CIO. So sometimes the investigators, HQIU will have a case that they're working, and they'll do a dual referral. They'll refer it to us to take administrative action against the license, and there may be some criminal elements, so it'll also be reported to their local DA, district attorney, I'm sorry. So it's after an investigation process because, of course, we're looking at the administrative side of it also.
Great, thank you. No further questions.
Thank you.
Thank you. Additional questions from board members? All right, seeing none, Angel, I'd like to open it back up for public comment, please.
Okay, so first one we have is Susan Lauren.
Hello, you can hear me?
Yes.
Thank you. As far as the experts having prestige, you're giving them prestige to lie in court. As I spoke of earlier today and have spoken of for years, the board affiliation confers authority to these witnesses in court. Terry Dubrow made a lot of money as the supposed independent medical expert. There's nothing independent about it. He got paid a lot of money. I know something needs to be done, and he needs to be off as an expert. And as far as there's no good expert for a bad procedure. And I recommend that plastic surgeons do not act as experts for each other. It's a field of harmful non-scientific procedures that began after the medical board was started, and we're in a lot of deep water with this. And you can see as well as I can, the case is just coming before you, but you don't see what I see for 10 years in the groups of women crying out by the multi thousands, their lives are ended. And don't you dare look bored with this, because this is life and death. And medical, I call your bluff about my case. Salzberger stabbed me 8 times in the butt for no reason and removed it. And you're telling me that, I'm sorry, my voice, I'm very tired and in pain. Bring it down. You're telling me that your board couldn't do anything about this criminal act. That is, so everything I hear you say, it's nonsense. And if you want to cut down on your workload, and by the way, I do appreciate the hard work you're doing. Don't get me wrong with that. It's just, I'm obviously, have grave consequences here. If you want to cut down on your workload, you need to stop the medical scams in which doctors sell people on propaganda that hurt and kill them. And until you do that, you really can't call yourself a medical board. You're licensing snake oil. It's doctor-controlled, fabricated records. You're never going to protect the public that way. And, in the Kenneth Hughes case, the expert was said to lie profusely. You've got Dubrow here, and I'm sorry, I'm reading from little notes I took, and last thing I wanted to apologize to the woman who shared her heartbreaking story and give my condolences. And my comment was in no way meant to invalidate or minimize your feelings as another victim of medical harm. My hope is to support all victims, and it wasn't my intention. My intention in the comment was a comment about the medical board. Thank you for your time.
Thank you for your comment. Next, we have Dr. Ree. Go ahead, doctor.
Yes, thank you. Hello, this is Hannah Ree with Black Patients Matter. So, medical board, I have a great idea that I've been putting out there, and I just know this is where we're headed. I just know it. Medical board, we're all headed to mediation. Mediation is our solution. Mediation, where patients can sit with the doctors, get some answers, cry together, hug each other, exhibit forgiveness, caring, love. That's where we're headed. Right now, we need an off ramp. We need an off ramp from this crazy highway that leads to the AG's office. Okay, so I'm telling you, medical board, I can see it. It's written in the stars. I read my Bible. Jesus told me we're headed to mediation. And so I just wanted to be the first to say it, because mediation, we can allow nonprofits to benefit. We can take all the silly money that we're throwing away to these experts, throwing money to the AG's office, increasing the fees. It's pointless, because we're going to mediation where we can sit down maybe at Starbucks or somewhere and talk with the doctors, talk with the patients, let people vent, let people cry, let people say, I'm sorry, let people hug and show love. It's all about love. And so that's what I foresee. That's what I want to reassure everyone. There will be a shift in the paradigm ahead. And maybe there'll be money left over. Leftover money, we can do other things like offer scholarships or financial help to those who need it. And so mediation is a lovely thing. It spreads the money around. It doesn't just lock it up in this black hole
30
called
seconds.
the AG's office, or this medical experts will never be able to match, the funding from the other party. So, any event, that's where we're headed. Okay, thank you.
Thank you for your comment. Next, we have Rosie Arthur's daughter. Go ahead.
Yes, that's right. That's my Swedish name. My comment is regarding the expert reviewer program, and I have some questions about organizational issues around it, because on the internet there are guidelines for the various different types of experts presented. And one of my tasks in life has been as an analyst. So, I'm always looking to reconcile between whatever is in this document or that catch of information and whatever else is out there. And I do notice inconsistencies between the reviewers' guidelines and the actual cases that are brought. So my question is, only having access to what's on the internet, is, are you publishing the most current ones? Because those certainly should be out there for the potential targets of these investigations to know what you're looking at. And it seems reasonable to have those types of expectations out there for anybody who's trying to do a good job to know what you're looking for. But seeing as there are some inconsistencies, I don't know if that's a problem of the latest guidelines not being out there, or perhaps it's the training that goes along with how do you take these guidelines and facilitate a reasonable outcome that's consistent with the law and regulations and science and everything else. So that's my comment. If there are unpublished guidelines, then they probably should be published so that they're there for the public to see and anybody who has reason to see them. Thank you.
Thank you for your comment. Next, we have Eric Andrist.
Can you hear me?
Yes, go ahead.
Public outreach? What public outreach has been happening? Aside from Christina's personal agenda on her ambush that she failed to report to the police, I haven't seen any public outreach. In fact, we were talking recently that it seems like all NBC public outreach has dried up aside from the Spanish tweets that don't lead to Spanish speakers to documents in Spanish. That's kind of odd. You aren't even fixing the app so it works properly. I see, Bill, that you are still not mentioning why the stakeholder meetings have been discontinued. Are you responsible for that decision? And as for your legislative proposal, I love how you all take credit for everything, like you all just sat in a room and brainstormed together, and then most of that didn't come from advocate input at these meetings. You're like the worker that steals another worker's idea when it's a success and takes credit for it. You shouldn't be proud that the medical experts are the heart of your work. You won't even tell a victim who the expert is on their complaint, I guess for fear that they find out just how unqualified they are. Asif is exactly right, and I can't believe you're getting rid of any experts when you have a shortage of them to begin with. Remember Dr. Aaron Stone, one of your experts, screwed up a major case where the AG's office had to dismiss the case because of his actions? Nothing has been done to reprimand him as the expert. I wouldn't be surprised if he's actually still an expert. How many other cases did he screw up, and have those cases been pulled and checked? Rest assured, I'll be sending that question to the state auditor when the audit starts, along, of course, with all of Carrie Webb's illegal activities with the Public Record Act. As for closing complaints, I'll speak more on that tomorrow and have veteran Curtis Thompson call in to talk about the fiasco of his complaint and Jenna Jones' lame emails about it. No violation or not enough information means that the board didn't contact the victim to get the proper information to begin with and chose instead to just shut it down. I asked who the medical consultant was, even did a Public Record Act request with Carrie Webb, who shut it down. Heaven forbid the public find out that the consultant wasn't qualified. In my own case, I sent you my medical records where my surgeon proved that the prior surgeon had done my surgery wrong. How is that not against the standard of care, and why was the complaint closed? I'm living proof that the surgery was wrong since I suffer every day with terrible stomach problems. I've been in the bathroom 8 times since this meeting with diarrhea because of that surgery, causing me to have gastroparesis. But you all think that that's okay to close the complaint and let that doctor harm others. We've brought you dozens of failed cases over the years that should have been disciplined. Your explanation, Bill, is unacceptable as usual.
30
Speaking
seconds.
like a diction teacher doesn't make you credible. Thank you.
Thank you for your comments. Next, we have Marian Hollingsworth. Go ahead.
Hello, can you hear me?
Yes.
Yeah, thank you. Hello, this is Marian Hollingsworth. While I appreciate Mr. Pacifica's statement that the board is committed to keeping complainants updated as to the status of their investigations, this is not happening. People are not getting updates. I know 2 people who had complaints recently. One person heard nothing for almost 2 years regarding the status of his complaint. Then he suddenly received a letter that it had been closed. Sadly, when he told the doctor about this complaint when he first made it, she laughed at him and said the board would never go after her. Another person had been waiting for 18 months and has not received any update on her complaint despite requests for an update. So perhaps your investigators are not being transparent about their correspondence with complainants, or maybe there could be a form that complainants could sign attesting to the fact that they had been updated each step of the way. That could be helpful for everyone. And regarding Dr. Gananadev's concern that the licensing fees are so high, the membership fees of the CMA are twice what the licensing fees would be if that highest amount is approved by the legislature. The CMA charges $1,200 per year for doctors in the LA area. That's one of the highest in the nation. That requires both the CMA and the LA County Medical Society fee. Doctors are required to join both. They can't just join the local one. The board's proposed licensing fee of about $11.50 is less than that for 2 years. It amounts to just $1.57 per day. So that really should not be a concern for most doctors. Thank you.
Thank you for your comments. Next, we have Virginia. Go ahead, Virginia.
Hello again. For the licensing fee, let's remind ourselves that I've lost $1 million to medical errors. $1 million that I will never get back. Would you guys like to lose $1 million? And spend hundreds and hundreds and hundreds of thousands of dollars to heal from medical errors? And my case would fall into no violation because it is so many hidden little tiny errors. On top of that, experts should not testify at trials and impoverish people that have already been harmed. The doctor didn't just do one, it's done multiple trials. Why are doctors allowed to cause traumatic stress? The CMA and a lot of this stuff directly affects the structure of the brain. It affects the immune system, the neuroendocrine system. And you guys just let it happen. Our brain structures are being damaged, and you guys don't care. And the no violation code pile, how many of those are real cases of hidden records and falsified records and records that aren't true? That's what I'm curious about, because I bet you a lot of those non-violation cases are actual real cases, like my case would be. And we're hurt, and there's nowhere to turn. My doctor worked for my employer. My employer started the startup fund for my doctor. So my doctor helped my employer when I was contractually discharged after having an infection. So I go to my doctor needing help for this infection, not knowing he got the startup funding from my doctor, from my hospital. I couldn't get medical care. And there's nowhere for me to turn. It crashed my nervous system, the infection did, because I didn't have proper PPE. And there's nowhere to turn. I hope you do other people better. Because I really, really, really want my life back. Every day, I want my life back, and it will never be the same. Well, you guys enjoyed your holidays? I can't enjoy my holidays. I don't remember the last beautiful holiday I had. And you write letters, happy holidays, joy to you. It's not like what happens. Because you guys don't protect us.
Please conclude.
I'm concluded.
Thank you for your comments. At this time, we no longer have any more comments.
Thank you, Angel. We'll bring it back to the board. Are there any further comments or questions before we move on to the next item? All right, seeing none, we're going to move on to agenda item 10, update on revising guidelines for prescribing controlled substances for pain. Mr. Prasivka.
Thank you, Madam President. I think the board can be thankful that I will be brief. The project is continuing. I think we're very fortunate to have someone of the stature of a Dr. Mackey involved in it. I think he very accurately displayed the challenges that we face in bringing this project to conclusion, but also, frankly, the opportunities. We have assembled a very impressive number of experts. I want to thank Dr. Thorpe, for assisting us in doing that, as well as Mr. Brooks, who is a part of the task force. We have reached out to our experts. We have divided up the project. We have got preliminary contributions and guidance from our subject matter experts. In the coming weeks ahead, we will be in the process of compiling an initial outline of what we like the revision to look like. At that point, then, we will meet with the task force, look for additional direction from the task force, and the goal is to begin with a comprehensive schedule of stakeholder consultation, which we hope will begin to commence at the end of the first quarter and the beginning of the second quarter. As I indicated before, the goal here is not simply to replicate the advice of the CDC, which of course is very necessary and very helpful. We are looking to some unique problems that we have in California, and to have something that we think will be useful to practitioners and useful to the public. We understand the problems with access, and that has a direct implication for patient safety. But also the one thing that I took as well from Dr. Mackey's very important contributions is that it's important that we get this right, and that we have a comprehensive consultation process. We've assembled, again, a very impressive group of experts. There's a huge amount of expertise in state, and we want this to be an example of board leadership. And so I'm very excited by the project. We're making very good progress, and I'd be happy to answer any questions board members may have.
Thank you, Mr. Persifka. Are there any questions or comments from board members? Mr. Watkins?
Just a clarification question. So do we at this stage only have like subject matter experts and no patient advocates as part of the process? Because I heard Dr. Mackey being very praiseful for the patient advocate component, adding another dimension. So is that going to be part of the process eventually, or at what stage?
Well, at the next stage, the way that we have structured it all is that we have assembled the subject matter experts to identify particularly those areas which need to be updated in light of recent events, in light of changes to practice, as well as legal and regulatory changes. And of course, those people bring with themselves a huge amount of interaction with patient advocates. But then at the next stage of the process is when we will have comprehensive stakeholder consultation, and they will certainly include patient advocates. So that's at the next stage.
Additional questions, or should I open it up for public comment? All right, Angel, if you could open it up for public comment, please.
All right, Kristen Ogden, go ahead.
Thank you. Can you hear me?
Yes.
I would like to express my appreciation for this update on the guideline review, and also for Dr. Mackey and the suggestions that he made. I appreciate Mr. Persifka's clarification on the intent about how you will go about considering the CDC guidelines. I was not able to attend the last meeting, but I did read the draft minutes in preparing for this meeting, and I was somewhat concerned because the way the draft minutes read left me with the impression that whatever CDC guidelines were published, you were going to incorporate them fully into the California guideline, and I am relieved to hear that that may not necessarily be the case. I'd like also to express my thanks to my colleague, Ms. Anne Fuquay, who spoke earlier and requested to participate as a stakeholder. And I forgot to mention that when I had my turn to speak earlier, but I would like to once again make that request. Our group, Families for Intractable Pain Relief, represents some of the most seriously ill, long-term intractable pain patients in the country. And I think that Anne, as a patient and an advocate, and me as an advocate and a caregiver, that we bring a perspective that not many people have. And so I would just like to ask that we be considered as possible stakeholders to be included. Thanks again to Dr. Mackey, Dr. Thorpe for bringing him in, and for Dr. Thorpe's demonstrated interest in pain patients and the Guideline Project. Mr. Prasivka also for his efforts. And finally, I would just like to thank Ms. Lawson for her patience and professionalism in conducting meetings of this board. Thank you very much. Appreciate the opportunity to comment.
Thank you. Before we move on to the next commenter, I wanted to just make a point that we did receive a number, a fair amount of written correspondence on this issue generally, and I don't know necessarily whether it related to the prior presentation by Dr. Mackey or whether it relates to this, but please rest assured that all of that is also incorporated into the record. We've read all of those letters that we received via email, and I know that our executive staff too is incorporating it into its thinking on how to proceed. So I just wanted to acknowledge that. I believe Ms. Ogden, one of your organization, was the author of one of those letters. We'll move on to the next commenter, please, Angel.
All right, thank you so much. Next, we have Dr. Ree.
Yes, hello, Hannah Ree with Black Patients Matter. We just wanted to comment that having a seat at the table would be an honor, and being able to discuss and express our ideas and concerns amongst chronic pain patients, with African American patients would be a great opportunity to educate and to share our concerns. Thank you very much.
Thank you for your comment. Next, we have Virginia. Go ahead.
Thank you for having this, but I think it's a huge misstep to not include those who experience chronic pain in the first step. I think we should be involved all the way through. And you should also involve those who've had chronic pain that was treatable, that was labeled as chronic pain, and we had to deal with the chronic pain when it's 100% treatable. 3 years of my life, chronic pain, that was 100% treatable. And I'm sure I'm not the only one out there like that. So that needs to be addressed as well. And other modalities to work with chronic pain besides the current modalities. And also, understanding trauma and trauma-informed care must be, are you listening to me? I don't see you listening. Mr. Perkins. Mr. William, do you hear me? Can you please put trauma-informed care and understanding trauma in a part of this component? Because I can't understand you when you don't listen to me. That is an important part of pain, is traumatic stress and how it affects the nervous system. And doctors really need to be trained in this, and it needs to be a primary component in the situation. So will you agree to address that? Check yes. Yes, I agree. Will you agree to put trauma-informed care and understanding trauma in the pain thing, in the pain information? Because it's an important primary part of pain. No feedback. Okay. Well, I hope you do, and I hope you put for those who have actually treated pain that's actually treated, and people don't fall into chronic pain category. And I hope we're in the first part of the chronic pain committee, because that's where we belong, because we are experts. Thank you.
Angel, are there further comments?
Apologies, I was on mute. Thank you for your comment. Next, we have Anne Fuqua. Anne?
Yes, are you able to hear me, sir?
Yes, we can hear you now.
I wanted to echo what Kristen Ogden had said earlier. We are very appreciative to you guys for the time that you've taken today and this evening on this issue. The patience that you've displayed. We're the patients, but y'all, you have been I guess you have been patient, and we know that we live this every day, and it gets incredibly frustrating to be in pain all the time, and that comes that it just it spills out at times, and we appreciate your patience and professionalism, and I guess as far as with the guideline, I was very, very, very glad to hear that this was not going to just what Kristen and I had both heard. It kind of, the rumor was that it would echo the CDC guidelines, and what they were going to do. And today has been very encouraging to hear that to finally see the draft, but to see that this is not just going to be a rubber stamp, a rubber stamp of that. We are all different. The way that we respond to to medications varies broadly, and then beyond that, there's the other medications that may be in someone's body. They're individual medical conditions that coexist, and we do a standard cookie cutter approach just does not work. Some of us like Kristen's husband and I, both of us, I said we're the quote unquote oddballs, weirdos, whatever you want to say. I mean, that's we don't have the we're the one percenters. That's a better way of saying it. And we just want the opportunity to have the best life that we can. And what has happened in recent years, has basically excluded the one percenters. It's just been, well, gosh, sorry, it kind of sucks to be you. This is what we have to protect the larger public, and we can take care of everybody without hurting some people. Thank you.
Thank you for your comment. Next, we have Rosie Arthur's daughter. Go ahead.
Thank you. One of the things that needs to be included in the guidelines for controlled substances is evaluating very carefully and assessing very carefully adverse reactions reported by patients. Instead of looking at them as being drug seeking and trying to get something, or ignoring it, or saying, oh, well, the insurance is going to deny your treatment if you say you have a reaction to it. There are a number of people, not a large percentage, but probably a large percentage of the people who have problems with adverse reactions have problems metabolizing medications. Either they're slow metabolizers, they don't metabolize it at all, rapid metabolizers, they can have toxic reactions, and you can have people taking very innocent medications, maybe an opioid painkiller, but not a lot, an anti-cholesterol medication. Yeah, okay. Oh, they have a sleep disorder, so they take something for that, and something for something else. And then you find out that they have a deficiency in metabolizing CYP450-2D6, very common in many medications. And there are tests to see if people are deficient in their ability to metabolize, or are rapid metabolizers that need a higher dose. And without that, you have people dying because they're being given the wrong combinations because this medication helps some people, or, oh, well, you're just drug seeking, or, well, I can't give you something for your sleep disorder because that's a controlled substance and I don't do that and this, even though they don't know why, or they don't know which ones are safe. Yet they have no qualms whatsoever, and the government insurance companies have no qualms whatsoever paying $340 a month to do a urinalysis for a person who isn't getting enough medication to start with, or appropriate medication,
30
rather than
seconds.
doing one simple test once. You know, you give a person Prozac, and if it's not the right medication for them, you've got big problems. You give them two medications that have the same metabolism path, and you've got a toxic reaction. It just seems simple. If you can pay $340 every month for your analysis, why not a test to see how a person who is having problems with medications, see if they have a deficiency? It just seems a simple guideline. Thank you.
Thank you for your comment. I did see a hand for Susan Lauren that kept going up and down. Susan, did you have a comment?
Actually, I figure we're all pretty tired, so I decided not to. Thank you.
Thank you. At this time, we no longer have any more comments.
All right, well, we'll bring it back to the board. And that, are there any further comments? Any board members want to offer anything on this item before we conclude for the evening?
Conclude.
All right, I'm sorry?
Conclude. Thank you.
Conclude. Well, that was our last item, and so the board is now going to be in recess until tomorrow morning at 9 a.m. So hope you all and all the members of the public have a good evening, and we'll see you early tomorrow. Thanks, everyone. Have a good night.
Thank you.